So I'm gonna give it a few minutes for persons to sign on. Okay, we have 5.
Are you hearing me well?
Yes.
Good.
Good evening, good evening, good evening. Welcome to a wonderful breast cancer conversation this evening with Jamaica Reach to Recovery. We're just going to give our viewers a few more minutes. We have a few persons on. We're just giving a few more minutes for more persons to come on, as we don't want to miss this very valuable information from these experts in the field of breast cancer. I myself am a survivor, so I'd like to share my knowledge on surviving. Good evening, good evening, good evening. Please share, tag a friend, invite a friend, male or female, it really doesn't matter. Hi, Terry, good evening. Please call a friend, tag a friend, share with a friend. Thank you for joining. So good evening, friends. Once again, thank you so much for joining this very important conversation with Jamaica Reach to Recovery. My name is Sandra Samuels, and my capacity, I'm speaking to you this evening in my capacity as the host and a survivor of breast cancer for 22 years. We want to welcome our very esteemed panelists. We have Dr. Mambi Alexander, Jennifer Mambi Alexander. We have Mrs. Carolyn Graham. She is the chairman of the Jamaica Reach to Recovery. Dr. Danielle Smelly, she's an oncologist. Dr. Hugh Anthony Roberts, he is a surgeon. I'm having a little technical difficulty. Looks right here, trying to get to my co-host. and it's not happening. But in the meantime, I would like to first of all invite Mrs. Carolyn Graham to bring welcome, kind words, first of all, from Jamaica Reach to Recovery, and just tell you a little bit about Reach to Recovery. Good evening, Carolyn.
Good evening, Sandra. Good evening, panelists. It's wonderful to be here. This is our very first webinar. It may have a few glitches, but I'm sure Sandra will be able to sort them all out. Jamaica Reach to Recovery. I'm sure many of you don't know that name, but we are the breast cancer support arm of the Jamaica Cancer Society. Now, although you may not know our name, we have been around since 1977, when we were founded by Dr. Denise Thwaites, when she became a breast cancer patient and saw the need for support. We are a support group, as I said before. We are all breast cancer survivors. We are all volunteers. And we provide support in all its forms in terms of encouragement to a patient as they go along the journey from patient to survivor. We provide emotional support. We provide some spiritual support. And we also provide some financial support. Now, what you may not be conscious of is that breast cancer is an expensive undertaking. The treatment of breast cancer is an expensive undertaking. And Reach to Recovery assists, where possible, women who need help to access tests and treatments. Now, our funding has over the last few years been from a 5K. For the last 5 or so years, we've had a pink run. The pink run may resonate with some of you. And the pink run was our primary source of funding. Now, there's a saying, it takes cash to care, and that's very true with breast cancer. So having not had the pink run for the last 2 years, we're not in as good a position as we would like to be to assist these women who very often simply cannot afford the tests and the treatments that are necessary. So what I'd like to say this afternoon is Reach to Recovery assists women who haven't had any men. I know there are men who also are breast cancer survivors, but we never seem to see them. So we assist women who need to get tests done, who need to get treatments done, and simply can't afford it. So if at the end of this webinar, after seeing all that happens from start to finish with breast cancer, you feel moved to assist us, you can call we have a desk, a reach desk at the Cancer Society. You can reach us at 876-978-0375. Or you can put everything in a wheelbarrow and wheel it over to us at the Cancer Society's office, which is at 16 Lady Musgrave Road. But it's not all about money. Money is important, yes. But we really are concerned with helping women to get to the stage in their breast cancer experience when they feel almost fully back to normal. And that is our mission, to get our women to the stage where they're comfortable in their skin and they're no longer afraid of what breast cancer means. This afternoon, we'll be looking at breast cancer from start to finish. And I'm sure there'll be a lot of things that you never knew about breast cancer that you'll hear this evening. So sit back, listen, and enjoy. And I want to particularly thank our viewers for coming in, because this is a Sunday afternoon and there's so many other things you could be doing. And of course, our panelists who have graced us with their presence. Thank you all.
Carolyn, when does Jamaica Reach to Recovery meet?
We meet virtually now on the second Tuesday of each month at 5:30. The credentials for the meeting can be obtained at the Reach desk. Just call 876.
Will we be able to post it also on our Facebook page?
Yes, you can do that. Yes, you can do
Okay.
that.
Okay. So can we have that number again?
876-978-0375.
And for those of you who didn't get it, I will be posting this webinar will be posted or uploaded on the Jamaica Reach to Recovery page, Facebook page, or it will be also on my page, or it will be also found on YouTube. So if you did not get all the information, you can always go back and listen to it over and over again. Thank you so much, Caroline.
Thank you very much, Sandra. And I'm
You are
sure
welcome.
everybody at the end of this will be so happy that they spent the time with us.
Thank you so much. Now I go to my sister friend, Dr. Jennifer Mambe Alexander, and we're going to ask my wonderful friend and sister to really, first of all, tell us a little bit about herself. She does the actually pathology, which is the report that is done when the sample is taken from the breast. And so I want Jennifer, please, Dr. Alexander, please just tell us a little bit about what you do, what your experience has been, how long you have been doing this, and what are some of the things that you can share with us. And I know you're very passionate about preventative measures, so I know also that you'll be sharing with us some of the preventative measures that you'd like us to know. So welcome, and you may begin.
Thank you. Thank you. Thank you. I hope you're hearing me well.
I'm hearing you very well.
Good, good. Thanks for inviting me. It really is a pleasure to be here. I've been doing this for years with Sandra, and I just want everyone to know that I can relate to breast cancer. I've been a breast cancer survivor for over 33 years. I'm stage 4 breast cancer, and I keep going on. So I'm so grateful to be here to share my experience. Hi, everybody. Okay, so there are one or two things I'd like to speak about first. And yes, I'm a breast cancer survivor. I had it in my 30s, and I was frightened and I was devastated, and I thought I was going to die like every woman thinks when she gets breast cancer. But I did everything I could. 30 years ago is much different from now. The treatment there is different. Today, everything is fine-tuned and actually easier to manage. So it's not a good idea to get breast cancer, but I think we'd be better off having it now than we did in those days. So I have survived breast cancer for over 30 years. Sandra was my patient. We went through some tough times, and we're friends.
Yes.
Apart from, well, I have evolved into being a fine needle aspiration biopsy expert. And what does that mean? It only means that when you get a diagnosis of breast cancer, many times the patient is sent to me for a diagnosis. And the easiest thing for me to do to make that diagnosis, easiest and quickest, is to just put a little needle into the lump, extract some of the cells, look at it under the microscope, and make a diagnosis. I may also use that material to do further studies, hormone receptor studies, and that's also something that I offer. I just want to give you an idea of what the procedure looks like. That's a book that I wrote, and that's the needle going into the lump. And the procedure lasts 10 seconds, no more. It's not very painful. It's not worse than a blood test. Many women say, "Are you finished?" when I'm over long before. So it's not a difficult procedure, and it's quick. It's tolerable. It gives the results that are required. And I can actually get those results out, if necessary, in 24 hours, but I don't usually do that. It's called a fine needle aspiration biopsy, and it harvests the cancer cells as well as some of the normal cells. But my training allows me to distinguish cancer cells from normal cells. At the end of the procedure, the patient leaves with a Band-Aid. Doesn't require pain medication, sutures, anything else, and can go back to work, can go back to physical activity. Patients usually ask me if they can come in for the biopsy if they have had, if they're on blood thinners, and I usually say yes, just stop it 24 hours before you come in, and you can restart your medication right after. Eat a meal before you come, have your breakfast, everything is not a big deal. After, it takes about perhaps sometimes 3 to 10 days to get the results out, which I usually send back to your doctor and they discuss it with you. But many times patients come to pick up results from me. I don't like to discuss the results with them, but sometimes for some reason, it turns out that we speak about it. Or they call me after they've gone to their doctor knowing that I've had breast cancer, and they just need to speak to me as a survivor. It is so good for a patient to see a live person who is doing well, who can say, I have been there, I have done that, I have walked your road, and I can guide you. I do that many times, Sandra does it many times, and all the members of the team of the Reach Recovery Group, they do it all the time. Instead of focusing, though, on my so-called fine needle aspiration biopsy, which gives you a result, I wanted to spend a little bit of time on speaking on prevention. Because if you prevent, then you don't have to cure. And it is important to recognize the links between elevated hormones and ill health. Particularly true for the hormone of estrogen, which is the main hormone in women. Estrogenic cancers like breast cancers occur. Estrogenic cancers like thyroid, ovarian, uterine, and lung cancers are also those kind of cancers. But they can be managed with a sensible diet and a good, healthy lifestyle. I think that for me, I think my lifestyle has helped. Yes, I went through the treatment. I had a mastectomy. I had chemotherapy, and eventually I had radiation therapy. But still, people who know me can say I have been this size since they've always known me, because my lifestyle is good. So there's a strong link between hormonal imbalance and breast cancer. And these hormones include estrogen, androgenic hormones like the male hormones, and so-called insulin-like growth factor. So it's important to keep your hormones in balance. Don't keep them too high and don't keep them too low. Breast cancer occurs in families and in women who do not have a family history of breast cancer, but it's only about 5% of women who get breast cancer with a family history. Most persons do not have a family history. I didn't have a family history. So it has to be, you have to really, really recognize that having a family history of breast cancer does not necessarily make you a risk for breast cancer. But I think what I'd like to share with you, when persons tell me my mom and my sister, they've had breast cancer, sometimes I wonder if they're not all sharing the same lifestyle. They're all sitting around the table, eating the same junk food, drinking the same stuff, not exercising, and then say, oh, I have a family history. It's probably a lifestyle history more than a family history. So what causes cancer? A mutation. A mutation is a change of a normal cell into an abnormal cell. And we're hearing about mutations now with COVID. And everything is a mutation and a mutation and mutation. But we have to realize that once a normal cell mutates, become a cancer cell, that cancer cell divides and keeps dividing to form a tumor, which can spread from the original focus to something else. And that's what we're trying to prevent. Cancer set up their own blood supply to keep growing, because that's why they're there. They usually start in the ducts and the lobules, then they move to the lymph nodes under the armpit, And perhaps if they're there long enough, they will spread to other areas in the body. Normal breasts contain receptors for estrogens and progesterones, which are our main hormones. And if you get a cancer developing from that kind of breast cancer cell, you will likely produce a cancer that is also hormone positive for estrogen and progesterone, which is not a bad thing, because then we know how to control it. If your cancer is not hormone sensitive, we don't know what's driving it, and it is a little bit harder to treat. So one of the medications that we give after diagnosis of breast cancer is something called Tamoxifen, which you are given and told to take for a certain time, not more than 5 years. It's usually given to women who are premenopausal. Postmenopausal women are given something else called aromatase. So, what are some of the signs of estrogen dominance? PMS, worsening PMS, low libido, fertility issues, ovarian cysts, heavy periods, they've included cellulite, fluid retention, and endometriosis. Now, it's important for you to know you have good estrogens and bad estrogens, and it's the bad estrogens that are associated with the development of cancer. But you have more power than you think over the development of breast cancer. Now, what should you do? When I got my breast cancer, my first thought was, what did I eat? Or what wasn't I eating? In my reading now, I have read that there are cruciferous vegetables like broccoli, cabbage, and cauliflower that are actually protective against the formation of breast cancer. So you can start adding a little bit of that to your diet. And you may want to, the liver is also important in the development and the growth of breast cancer, because it breaks down estrogens into clean estrogens, bad estrogens. So if your liver is not functioning well, you may have more bad estrogens than good estrogens. So what else you need to do? Calcium glucarate is good, is protective. And I've also found that I'm telling persons now who have COVID, take magnesium, take vitamin C, take vitamin B complex, and take zinc. And these are good recommendations for persons. These are good lifestyle medications to take. They will really make you better, and they will decrease your risk for getting breast cancer. Dandelion leaves, flaxseed, apple cider in half a glass, half a lemon, or half a lemon to a glass of warm water is very good. It flushes out your system. Pumpkin seed, sunflower seed, and sesame seeds. When you are barbecuing, which everybody loves to do, don't quick barbecue it and don't burn it, because that burn on the outside has cancer forming properties. So it's good to perhaps marinate it before and cook it slowly. And you see, when the family sits over that kind of food and everybody eats the same thing, you think you have a family history of breast cancer. No, it's your lifestyle changes that are influencing you. Olive oil decreases the incidence of breast cancer, and so does coconut oil. So they say when you're eating, put a rainbow on your plate. Carrots and different colors. Cut down on the red meat. Eat more fish. Cut down on the bread and the white bread. Eat more natural products. Even potatoes are better than the bread, because potatoes are natural. So watch your meat intake. And go outside in the sun. Take some sun. You know, some of us, what we do is we leave our homes, we jump into our cars, we drive to work, we go straight into the office, we sit into an air-conditioned office, no light, no sun, no windows. We leave that in the afternoon to jump back in the car, and we go home and go inside. And there's no sun exposure at all during the day. It's the same thing I tell people for COVID. Try to do that for your breast cancer. Chronic illnesses. You don't want a chronic illness to develop, and these are good things to do to stop developing chronic illnesses. Cut down on your red meat, cut down on your alcohol intake, meditate or listen to soothing music, cut down the stress in your life. Do
For
not
sure.
do not have stressful relationships.
Yeah.
Walk away from stressful relationships. Those will kill you. Throw away your insecticide to spray the fly and get a fly swatter. It actually gives you a bit of exercise and it is healthy for you. What else I have to tell you? Kick back on smoking, drinking, and other types of illegal drugs. Don't use them.
So in essence, Doc, a
Whole
healthy
lifestyle.
Everything in moderation. Well, most things in moderation. Cut out the things that we know we need to cut out. Sugar is the enemy. We know that for sure. I've been told that many times. And so if anything, we will come back to you, Doc.
No, man, I can't stop now.
All right.
Just
so
have
let
a
me
good night's sleep.
introduce. Thank you so much. So now I'll introduce my co-host, Miss Althea Lawler. I call her Raquel. She's also known as Raquel. She's the owner of this salon. She's also a trichologist and an excellent cosmetologist. And so in her capacity this evening, she's also a survivor. She is a trichologist, which she'll talk to about hair care later on. But she's also my co-host. So I'm going to hand over to her now to introduce two doctors that we have on the panel so that they can bring you their information.
Oh, Sandy, thank you for that warm welcome. Good evening, all those who's on the panel, those who's watching out there in social media land. Thanks for joining us this evening. And I want to take this opportunity to bring on Dr. Anthony Roberts. It's a pleasure to sit in right here with you and being your present. So Dr. Roberts is a consultant surgeon at the Kingston Public Hospital, KPH, an associate lecturer at the University of the West Indies, UWI Mono, a coordinator of undergrads, surgeons, a surgical student at KPH, director coordinator at postgrad, a general surgery program at KPH, examiner undergrad and postgrad at UWI medical program, President-elect Vice President of Association of Surgeons in Jamaica, ASAJ, head of membership of Committee of the Caribbean College of Surgeons, Fellow of Caribbean College of Surgeons 2012, Fellow of American College of Surgeons 2015, married to a Jamaican father and Barbadian mother. He loved most sports. So I hope you have seen Formula One today, Doc.
A little disappointed with the result, but hey, it's not over.
Welcome. Not over until it's over.
Not over.
Welcome.
Yeah, man. Thank you, everyone. I want to thank the Jamaica Reach to Recovery. I think that breast cancer is something that I am very passionate about. I have done a few other talks with some of you. Obviously, I know Dr. Smelly very well because we work together hand in hand at KPH. Even though she's moved on to slightly greener pastures to the Kingston 7 area, but we're still at the Hope Institute. So we're here to talk about breast cancer. Thanks to Dr. Mambi Alexander for starting us off. So breast cancer is the number one cancer that we know amongst women, and not only affects women in Jamaica, but this is worldwide. Taking out of obviously skin cancers, which are not really endemic in this area. It's something that we need to tackle because unfortunately we have not found what the precursor lesions for breast cancer is. So when breast cancer month comes around, we always talk about screening and awareness and everything, and I want to go a little bit into that. Um, because screening is where you try to pick up the disease at an early state in this scenario. In some scenarios, for example, colorectal cancer or cervical cancer, we do understand a little more the biologics or the way how the cancer actually forms. So we're actually in those situations are allowed to pick up the precursor lesions before the cancer develops. But unfortunately for breast cancer, we don't know what those precursor lesions are. So what we try to do is pick it up at an early stage, which is usually like stage one or worst case scenario, stage two. It's what we want to achieve. And that's where the mammogram comes into play. So the first thing I would say when it comes to screening is that you have to know your risk assessment. And usually persons are put into two groups, average risk and high risk. As Dr. Mambi said, the majority of average risk patients are those who are in society that have no family history, and that accounts for about 85 to 90% of the cancers that we see here in Jamaica and across the Caribbean. And that's what we call sporadic type, meaning you don't have any family history, you don't have any genetic history, you just get it, and you don't know why. And I think one of the important things when it comes to screening is that not only are you trying to improve the outcome for patients, but another part that Ms. Graham made in her introductory speech was the difference in terms of the financial and economic costs of stage 3 disease versus stage 1 disease and breast cancer is almost 3 times that. So this takes into consideration raw figures. You're talking about $2.5 million for probably stage 1 or a little bit less, and all the way up to $7.5 to $10 million for stage 3. And that's because of the additional drugs and additional treatment that you need to in the management of patients who have stage 3 disease, which is what you're trying to prevent, how people present. Now, one of the things is, so that's screening. When should we start screening? In our 40s. You might see studies coming out in North America and Europe about screening after 50, but we should really start screening by 45, no later than 50. And the reason for that is because, unfortunately, in our population, we have a majority Black and other minority population. And unfortunately, we find that amongst those populations, breast cancer tends to be a little bit more aggressive. And sadly, it also presents at an earlier stage. So if you compare our figures with the United States, we find that the median age that people present in North America is around age 60, or we find that is around 52 to 44, depending on what study you're taking out of Jamaica. But that's at least 5, 6, 7, 8 years earlier than what you see in North America. And what you also see with our presentations, that you see that we have a threefold increased presentation at the advanced stage, which is stage 2B or later, than what you could see in North America. And the main reason for that is because we don't have a fully active screening program. And the point I want to make, and it's probably something that I don't necessarily make to you guys, but the point I want to make is even though we celebrate and we try to bring awareness of breast cancer and look at the survivors of breast cancer in October, we still have another 11 months where breast cancer occurs. So it's not that we need to remember it for 30 days, 31 days, and then, okay, we chill for another 330 days, and then you come back. You know, you need to be aware of what's going on. You need to be vigilant about it. You need to talk. I think one of the good things with the Jamaica Reach, the recovery group, is that a lot of times when women feel that they develop breast cancer, they feel alone. They feel that they're the only person that has breast cancer. Why me? But then when they go to start their treatment, especially when they start like chemotherapy, and they realize that there are many other women who are there with them to get to share their experiences. So this is also another way that women can share their experiences through the Jamaica Reach, the recovery program. Now that's screening. So one of the things the screening looks at the asymptomatic population. That means
Doc, before you go past the screening, you said you only need to start screening at 40. Is there any difference if you have it in your family? Should you start any earlier if
you are high
in your
risk?
family?
Yes. So if you are high risk, it is individualized on what makes you high risk. For example, if you have a genetic predisposition or you have a strong family history. And what we try to look at is the age at which those family members may have developed breast cancer, or if you can, have genetic testing done, which is one of the advances in the treatment of breast cancer right now. Because we can do genetic screening for the patient who actually had breast cancer as well as other family members. And those swabs can be done here in Jamaica, but they're just sent abroad to North America. And you usually have a 1 to 2 week turnaround in results in terms of getting them there and getting back the results. And obviously, when you get back the results, you can counsel. But certainly, you would start at an earlier age. And what you're probably asking is, what is that specific age? There's no specific age. It depends on the individual situation. Now, one of the things that will change though is that the mammogram is quite sensitive as you get older. And what that means is that the pickup rate of the mammogram for any lesions is better in persons who are in their 50s and 60s and so on. And that increases as you get older. But when you have younger persons in their 30s and even in their 20s, the sensitivity or the pickup rate of the mammogram is low. So what you may also have to do with those persons who may have a strong family history or genetic predisposition is that you might have to add another radiological investigation, such as an MRI or even a PET scan to investigate those patients. Clear?
Yes.
All right. So screening is what we do for the asymptomatic population. But for the symptomatic population, meaning the person who has picked up something that's abnormal with her breast or his breast too, because we know breast cancer can also occur in men, even though extremely rare. The most common presentation, as you guys probably know, is a lump. And a misconception is that as long as the lump is not painless, it is not cancerous. Well, to be honest with you, if you do have a painless lump, the likelihood of it being cancerous is very low. It's more like an inflammatory or infective process, unless it is that you have advanced cancer, such as inflammatory breast cancer, which means it's an advanced stage. Most persons who have a lump with breast cancer, it's painless. But the odds are still in favor of women who do have a painless lump of it being benign. So the important thing is if you do discover a lump or any other pathology in your breast, such as nipples, scarring, or the area of dimpling, even a lump under the armpit, even nipple discharge, which is not really associated with breast cancer. The important thing is to seek medical attention. So,
Wow.
and medical attention is usually first with your GP or your gynecologist. You're not going to see me or Dr. Smiley as yet. Right? Your first encounter is usually with your GP or your gynecologist. And usually, obviously, that means that they'll carry out, ask you a couple of questions, which is what we call your history. Then they'll examine you, and most likely they will send you for radiological investigations, which usually comprise of a mammogram and an ultrasound. And the importance of that is that the radiologist will give you an objective score that can help the physician who is seeing the patient assess whether this lump is more likely benign versus whether this lump is more likely cancerous.
Dr.
And
Robert, may
yes,
I just interject and ask a question there?
of
What
course.
if you find a lump and your radiologist said to you it is a cyst, and then a few months after you go back and it was mammogram, ultrasound, and said it's still a cyst, but the fluid that was pulled from the cyst was not tested, and but you're insisting as a patient to get this lung biopsy because something is wrong, because I heard what you said about painless and pain. This pain was, I had to take something for the pain, and I was always told that all breast cancer is detected underneath an ultrasound or a mammogram, which this one was not detected underneath that particular imaging any at all.
All right.
Where
So,
do you go from that? How do you direct that patient now if she insisting that something is wrong?
so the first thing you raised a couple of points, and let me go in reverse. The last point you made about breast cancer being picked up by ultrasound and mammogram is not true all the time. Up to 10% of cases are not picked up by the mammogram, and about another 10 to 15% are not picked up by ultrasound. It depends on how the cancer presents. So, and there's no radiological investigation that is 100% accurate. So, this is one of the reasons why we combine the mammogram and the ultrasound. And for me, I'm a very conservative, cautious person. So it means there's nothing wrong if you don't see anything now to say to the person you're going to repeat the study in 3 weeks or 3 months' time. And it should be, in my opinion, repeated by the same person that did it the first time so that they could at least be, you rule off the biasness of two different people reading an ultrasound or a mammogram. The second point is that at all times the patient has autonomy. You have to understand that the patient has full autonomy or control over what actually goes on. My job is not to tell you what to do. My job is to tell you as a professional what I believe is the best thing for you. Now, at the end of the day, if it is that you want something to be tested, you have every right to have it tested. And I guess Dr. Mambi can talk about this. Legally, if you pull fluid off from somebody, it should be sent for cytological analysis.
It should. It
Right?
should.
It should be
Right.
sent for cytological, and Dr. Mambi would tell you it takes her about 5 seconds. Not 5 seconds. All right, you got to fix it on a slide, but it takes her literally about an hour to read it on a slide.
Right.
Right. So there's really no harm, and I've had patients where I've said to them, I don't think anything is wrong, and they have insisted I feel something is wrong, and I've erred with what they've said, and it has come back being cancerous. It's not that I've been wrong, because I can only tell you what I feel or what I see.
Right.
Right? This is why there are radiological investigations, and then you also have to remember there are also things that the woman's breast changes. All of your breasts change based on your menstrual cycle. For those who still have menstrual cycles, you remember that your breast becomes larger, more engorged. Any masses that you have seem to be larger just before you have your period. So there's also the possibility of when you felt something or when you suspected something and then you went to the doctor a few days or a few weeks later, it might be a different scenario because things are not static. They're in fluidity. So the take-home message for me to you is: one, patients always have autonomy. Two, physicians must always listen to their patient and err on caution. Three, there's no radiological investigation that is 100% correct. And four, the only person that can tell you what something is Dr. Mambi or her colleagues, a pathologist. Right? A radiologist can tell you it looks like a duck. A surgeon can tell you it sounds like a duck. Right? Everybody can tell you something. The only person can tell you it's a duck is the pathologist. And that can only that can only happen if you have some kind of cytological or histological analysis of fluid or tissue. Make sense?
Yes.
Okay. I can't remember what else you asked. I think I answered all of the parts of your question. I don't know if I
I
did.
think you have covered my question because I am so grateful for this platform because I'm speaking in the third person, but I'm just talking about my journey. And I want women and men who even feel a slight difference in their breast or their entire body is to insist, because I think that we put our doctors on a pedestal that we are afraid to say things to them. And when we go, we have all the things that we want to ask you guys. And when we get there, it totally goes to the door because no, you look like a monster in front of us. I just want the audience to understand that if you give your practitioner the chance, you will get the answer, because they have to listen to you. You have to listen and give me your opinion after I have given you. I'm telling you all what I'm feeling, because all of this scenario take place from January until September of me going back 8 times. The one person.
Well, let me talk quite frankly to you without saying anything derogatory, right? No. The derogatory is not towards you; it's towards my colleagues, right? Medicine is no different than any other profession, right? The job that Dr. Smelly, Dr. Mambi, and I do is a PR job. People come to me because they think I'm nice. That's reality. They think I sit down in my office, I listen to them, they call me on the phone, I answer my phone. That's me, right? That is me personally. There should never be that fear of you going to your doctor, right? I've always heard that there are 4 persons in life that you should always feel comfortable going to: your accountant, your lawyer, your doctor, and your pastor. Those are the 4
Not
persons,
pastor one. But
right? I'm not gonna go into whatever religion you are or whatever. I mean, because that pastor thing kind of sensitive in Jamaica right now, right? But the reality is that you should feel comfortable having a discussion with your doctor. You should feel comfortable asking your doctor questions. I do not know every single thing. And there are things that when I say I am not sure, I will go and check because I know where to research it. But you have to have an open conversation. That open conversation goes in both directions, because the only person who is going to suffer from a lack of an open conversation is you. The other thing which I would recommend to any patient is this: there's nothing wrong with getting a second opinion. When my patients come to me and they're confused about something or they're not sure, I say, do you want to get a second opinion? Right? And I've had numerous patients that come to me and get a second opinion. So I'll give you the reverse scenario. When a patient comes to me and gets a second opinion, I tell them, don't tell me what the first opinion is. I will see you as if I'm seeing you the first time, and let's make a pact. If my opinion is the same opinion as the first person, go back to the first person. If my opinion is different to the first person and I realize that there are alternative ways of doing things and the person's way is right as well, go back to the first person. If it is a situation where I've said something different to you and you tell me what the first person says and I don't agree with it, I will tell you diplomatically that I don't agree with it. But the ball is still in your court of if you're going to stay with me or go back to that person because it is your body. Is that fair?
Can I just add something? Because you said that you had all your questions and by the time you got to your doctor, you forgot. Write the questions down.
Yeah.
So that when you go to the doctor, they're on a paper.
Doc.
And sometimes it's important to take somebody with you.
Yes.
You
And
forget the answer, and the person said, no, he didn't say, he said this, he didn't say, but make sure you write your questions down.
definitely, or I'll take a patient navigator with me.
Yes.
Yes. Okay. So during Dr. Roberts' talk, we have two of our very esteemed panelists joined us. Miss Tara Playfair Scott. She's a PR and marketing consultant, and she will be speaking to us this evening on her journey. And Mr. Kevin Powell, who is a caregiver to his very lovely wife, and he will be telling us about his journey as a caregiver to his very lovely wife. I want to also about his. Can you mute your mic, please? There's a feedback. Very lovely wife. I want to also about his. Can you mute your mic, please? There's a feedback. Very lovely wife. About his. Can you mute your mic, please? Hello?
Yeah, we're here.
Okay, yes. So I would also like to welcome our viewers who have just joined us. Please remember, you have not missed anything, because once we are finished with this program, it will be uploaded on the Facebook page for Samuel Sandra and the Facebook page for Jamaica Reach to Recovery, and it will be also uploaded on YouTube. So you have not missed anything. So don't panic. It's a lot of information that has gone on, but we continue with more information. So Raquel will now introduce Dr. Smelly, and we will speak to the oncologist shortly. Unmute. Unmute.
I was there talking to her. Yeah, I'm getting used to this computer thing. Dr. Smiley, Daniel Smiley, is a consultant medical oncologist who did her undergrad and postgrad training at the University of the West Indies. She currently works at the Hope Institute in Kingston, Jamaica, regularly participated in care of patients with breast cancer. Dr. Smiley, welcome.
Thank you so much for having me. So thank you very much for the invitation. I also have to thank Dr. Worf for asking me to step in on her behalf, because I know normally she's your panelist of choice. And I appreciate that she has endorsed, my presence here this evening. So I think what I'd like to talk to everyone about is my first point that I want to make is to kind of reiterate Dr. Mamby's and Dr. Roberts's messages, and to add my own, which is basically to say that although we tend to talk about breast cancer as a disease of older women, if you are a young woman and you have a breast lump, that lump needs to be evaluated. And it's a very common scenario, unfortunately, where we have patients presenting who have been trying to get their lumps checked for months, and they're being told that because they're 27, it can't be cancer, and so nobody takes them seriously, they're not biopsied, and then by the time someone does take them seriously, their disease is advanced. So I want to just sort of reiterate that if there is something there and someone's not taking you seriously, as Dr. Roberts said, get a second opinion. Find someone who's going to take your concerns to heart and investigate you appropriately for what is going on. So that's my first message. My second message is, well, I just want to talk a little bit about my role as the medical oncologist in the management of patients with breast cancer. So generally speaking, by the time you get to me, you have already had your biopsy, we already have some tissue or some fluid, and we know for sure that the problem is cancer. For me, the conversation then ends up being more about, well, what type of cancer do you have? And people are often surprised to hear that there are different types of breast cancer, but there are. It's not one disease that affects all of this women. It's different forms of a very similar disease. And knowing the type of breast cancer you have informs the conversation we have about the kind of treatment that you would benefit from and the best way to lower your risk for your cancer coming back. And generally speaking, that's my job. I want to give you medication that is going to lower the risk of your cancer coming back. There are different types of medication that we can use, and the type of medication that we use depends on the type of cancer that you have. So generally, you can have cancer that is sensitive to hormones. You can have cancer that is making a specific protein, and that protein is called HER2. Or you can have cancer that is not sensitive to hormones and not making HER2. Those are the three big groups. Hormone-sensitive cancers can be amenable to hormonal therapy, and they may or may not benefit from chemo. And that depends on how big the lump is. It depends on how advanced it is and what stage you are at the time we find it. Cancers that are not sensitive to hormones and that are not making HER2 are what we call triple negative breast cancers. Those cancers tend to be more aggressive than hormone sensitive cancers, and we tend to be more likely to offer you chemotherapy as a way of reducing the risk of your cancer coming back within the next 5 years. It's important to know that for triple negative breast cancers, the risk of relapse is highest in the first 2 to 3 years after your diagnosis. So usually once you're well after your surgery, we want to try and start your chemotherapy as promptly as possible to remove any remaining cancer cells that may still be in the body, cells that are too tiny for the surgeons to see and to cut out. And then our third type is the HER2 positive breast cancer. HER2 positive breast cancer also tends to be more aggressive than the other types of breast cancer, and the risk of it coming back within the first 2 to 3 years also tends to be higher than the other types of breast cancer. It's also the type that's likely to cost you the most money. So while most of the chemotherapy medications and most of the hormonal medications are covered by the NHF, and so every single woman who's diagnosed with breast cancer should be signed up with the NHF, you should get that card because it makes a huge difference in your costs. Unfortunately, the medication for the HER2, which is the Herceptin, is not something you can swipe a card for. We've made progress in the last couple of years in terms of getting Herceptin available through the government system. It's not available to everyone. It's available to patients with specific stages of disease, but you can access it at the Kingston Public Hospital, the University Hospital, and Cornwall Regional Hospital. Generally speaking, patients with HER2 positive cancer need to get this Herceptin in addition to their chemotherapy as a way of drastically reducing their risk of relapse, because chemotherapy alone is not enough to keep that cancer under control. The Herceptin confers kind of special properties onto those cancer cells that make them divide faster. It makes them more aggressive. It makes them more invasive. And that's why that medication is so important. In the private sector, if you're trying to just pay for the Herceptin, it's something like $300,000 per dose. And you need 18 doses. That's 1 year of treatment. So we're really grateful for the strides that have been made in getting it available in the public setting. And I think it's important to know that even if you present to a private person for your care, you come to a private oncologist or to a private surgeon, if you can't afford the Herceptin, then we are going to do the best we can to see if we can get you in the public system and get you treated. So don't think that there's no help for you, because there absolutely is. We're all here to be on your team. We're all here to get you the best outcome possible. So usually if you finish your treatment, so for, as I said, triple negative and HER2 positive, it's chemotherapy plus or minus Herceptin if you have the protein. At the end of your treatment, you will then go into something called surveillance. If you have hormone positive disease, then usually your surveillance is what involves you taking tablets, anti-hormone tablets, to lower the risk of your cancer coming back. Traditionally, it's about 5 years, but more and more we're getting new information that says actually you may need to be on your hormones for up to 10 years after getting your initial treatment for your breast cancer. Your surveillance involves not just being on medication if it's appropriate, but coming to your doctor every 3 to 4 months initially for a checkup. We also do an annual mammogram on the remaining breast if it's appropriate. And we basically ensure that you are examining the chest regularly. We will examine the chest at your visit. And once you do your mammogram once a year, we go through your mammogram results. After about the first 2 years, if you're doing well, we decrease your visit frequency. We'll see you every 6 months. And then at 5 years, that's the time at which we say, okay, great, we've done a really good job. We've prevented your breast cancer from coming back. And, you know, we have a little party and we confer on you the title of survivor, because that's where we're trying to get you. And then thereafter, usually it's probably an annual visit with your oncologist, just one time for the year, just to do a checkup, make sure you're still doing your mammograms. Usually when women start surveillance, I will also have conversations with them about other age-appropriate screening, because you've now had one cancer and we want to make sure that you don't fall victim to something else. So if it's appropriate, I will talk to you about your colon cancer screening and have you done that? Do you know what it is? And we'll make sure to educate you about that, as well as your regular pap smears, if it's appropriate. So yeah, that's generally how your oncologist visit is going to go. Oh, you're muted.
Thank you. Sandy, unmute.
Yeah, Sandra, you're muted.
Dr. Smelly, you spoke about the different types of cancer. All right.
Yes.
First of all, the next thing is, how are you staged? How does one know what stage they're at? And two, what stages require what treatments?
Sure. So generally we stage you from stage 0 to 4. Stage 0 is what we call in situ breast cancer. It doesn't usually require chemotherapy or anything like that, but it may require hormones if that's appropriate. Stage 1 is where there's usually a lump, but it has not left the breast. The cancer is confined to the breast only. Stage 2 is where there's evidence of cancer both in the breast and usually in close by organs called the lymph nodes. Those are usually under the arm. Stage 3 is where the breast cancer is involving not just the breast, but usually multiple lymph nodes, but still hasn't spread to another solid organ. And then stage 4 usually means that it's left the breast and found another organ like the lung, the liver, or the bones to spread to and to involve. And the way that we tell the difference between these stages is usually with a CT scan. And the CT scan will be of the chest, of the tummy, and of the pelvis most commonly. And that sometimes we will also involve a bone scan alongside the CT scan to specifically evaluate the bones if necessary. The stage of treatment, if you're stage 1 or 2, we say that you have an early breast cancer. Stage 3 is what we generally call a locally advanced breast cancer. And then stage 4 is what we call a metastatic breast cancer, a breast cancer that has spread to another organ. For early breast cancer, generally speaking, you will either have your surgery up front and then come see the oncologist after your surgery to talk about additional treatment or adjuvant treatment. Or sometimes with stage 2 and definitely with stage 3, the surgeons may say, you know, we can probably get a better outcome if we shrink it first before your surgery. And then you will be sent to the oncologist to talk about what's called neoadjuvant, which just means before surgery medication to try to shrink your breast lump as much as possible to improve your surgical outcome, and sometimes to decrease the amount of invasiveness the surgery has. Stage 4, the treatment of stage 4 breast cancer really depends on how what organs are involved, how far it has spread. And that is a lot more of a more involved and more individualized discussion. And it can involve chemotherapy, it can involve hormonal therapy. There may also be a role for radiation, which I'm not going to get into because that's not really my specialty. And there may be other medications like bone strengtheners that we would have a discussion about if it is appropriate.
Wow, that's a lot of information.
It is.
Okay, so let me. Oh, go ahead, Doc.
I just want to add a point to Danielle, to Dr. Smalley's point. I mean, everything you said there was correct. The only thing I want to add to this, though, that even though it may be a situation where surgery occurs before chemotherapy, the hemoncologist is still involved with the management from the beginning. So it should be a decision that's made between both parties.
That's true.
All right. So in other words, it's not a situation where you necessarily operate on the patient and you just send them 3 or 4 weeks later to the hemoncologist. It's that you have a discussion on hemoncologist and you know what's going on with this patient. And then you make a decision, all right, we think this patient would benefit from surgery first. And then 4 weeks later, they would be already expecting what's going on with the patient. Because what you're really waiting for is 2 things. 1, to recover from surgery, and 2, for the final pathological report so that you actually know what pathological stage it would be. Because we don't actually give patients chemotherapy based on the clinical stage after surgery. You give it based on the pathological stage, which is the true stage. The clinical staging is only there if it is that the patient is going to get treatment before, as in chemotherapy or hormonal therapy before surgery. You can continue. That's my 2 cents.
Okay. Well, on that note, let us go straight to Tara to tell us about her experience with breast cancer. And Tara would like to know, like, at what age were you diagnosed? And then you can take us through your journey. Ladies and gentlemen who have joined us, thanks again for joining us. Please remember to send in your questions. You have the panelists here that can answer your questions. Do not waste this opportunity because this is very valuable information and we have the experts here that can answer your questions. So Tara, over to you. Thank you so much again for joining me. I know you're very, very busy and she has a time constraint this afternoon. So I just want to take her right now so that we don't want to miss her story.
No problem. Thanks so much for having me, Sandra. Hi, Carolyn. Good evening, Dr. Smelly, Dr. Roberts, Alfio, and Jennifer, we met earlier. How are you? And hello, Kevin. How are you? So, yes, thanks for having me. And, I love working with Reach to Recovery. They're definitely family. And I'm so sorry this pandemic has had us separated the last couple of Octobers, but we are here together today. So, yes, I am in year 5 now. I was diagnosed in 2016. And as I tell everybody every time I have this talk, I am exactly what you should not do. I am that person. And, but for the grace of God, I am here. So I did discover a lump. As Dr. Roberts pointed out, I chalked it up to it's right before your period. It's probably a cyst. It will go away. Having had a similar experience before, and I noticed it did not go away. But instead of going to get it checked, I instead began to self-diagnose. So I went on to Google and WebMD because they're there, and you figure you can type in the symptoms, and pretty much a lot of what Dr. Roberts said. I didn't have any pain with the lump. It was not that big. So for me, I just figured, hey, it's fibrosis. I had it all figured out. And so I just kept going. And I did this for maybe about 2 months. And then I realized, it's not going anywhere, but I still had already diagnosed myself. And so I called my cousin who has Fairco Medical, and I said to her, hey, I just want to pop by, maybe, see one of your general, doctors, GP. Just, I already know what I have, but I just need them to basically tell me how we're gonna, drain this cyst, or, what we need to do. And she, she's like, yeah, okay, sure. And I went to the doctor, and the doctor immediately said, did you do a mammogram this year? And I said, no, I'm pretty busy, not sure if I even need to really. And I, let's just figure out how we get, do we drain this thing? What are we doing? And she's like, no, you really need to go and just go, just satisfy me. Go do this mammogram, and, let's talk after you've done the mammogram. So I went and did the mammogram. Upon doing the mammogram, they told me, hey, we're going to need you to sit here and wait. You're going to have to do an ultrasound as well. And I was a little annoyed because I, got to go, got stuff to do. But all right, if you insist. And I waited, did the ultrasound, and then the ultrasound tech, who I was badgering with questions, was like, no, you're going to have to wait for the doctor to come in. But yes, we do see something here, but let's wait on the doctor. And then the doctor came in and said, hey, we're going to need you to do a biopsy. And I was really, really, really shocked, because it just wasn't computing for me. I didn't have a history of breast cancer. I wasn't doing anything, living a crazy lifestyle. I was fairly healthy, working out, ate fairly well. I didn't understand. Nothing to me was equating to this could possibly be breast cancer. So I asked if I could do that biopsy right away, not understanding how it works. So I was like, yeah, I'll just wait. Can we just go do that biopsy now? And she was like, no, you have to schedule it in. And I kept calling because I was leaving to go away for work. And they finally, she put me in 2 days later. And Dr. Cornwall did my biopsy, which I have to say, ladies, make sure you get your mammograms. If you have smaller breasts and you need to do something else, ultrasound and self-breast checks, please do that, because you do not want a biopsy. Nowhere, no time in life do you want experience. To me, it was the worst of everything. It was extremely painful, and I was ready to get up and leave. I just couldn't take anymore. It was really bad. So I had that done, and I left. I left Jamaica. I did. So as I'm saying, I am the wrong. Everything I did is what you should not do. So I left Jamaica, went on this diaspora tour. I see my mother in the audience. And I went up and did this diaspora tour. Saw my mom. Just was living quite normally, as if okay. I already knew what this was. And when I came back and called, they were like, we have been trying to reach you. You need to, you need to come on in. And I was like, all right, cool. Still not thinking anything. I went in. And she told me, yes, you have breast cancer. And I left my body. I don't remember the conversation. I legit don't remember anything about it, except she said it. And then I remember almost watching this doctor speak to me, but I wasn't hearing anything. I couldn't process. And then finally she said, should I call somebody? Do you want to call anybody? You want somebody to come and meet you? And I was like, no, I want to look at the paper myself. And she handed it to me, and I looked through, and I was scanning for words I could pick up, and I was like, oh wow, this is real. And I left. I drove home. I don't remember how I got there. I didn't talk to anybody about it. Went to bed, figuring you kind of would wake up and something would be different. Woke up and realized this was real. And at that point, I had to try to figure it out. So for me, I told very few people. I took a while to tell my own mother. I just wanted to get my answers. So a lot of what Dr. Smelly talked about, I started investigating costs. At that time, I didn't realize there were different kinds of breast cancer. I thought breast cancer was just one thing. So I started, Googling, yes. I started, calling up, trying to figure out costs. I called Carimed because I figured you treat this thing with, as you said, it's hormone. You try to find out Herceptin. I was like doing all this research, getting all my numbers in order. And then when I went back to the doctor, she said, no, we need to send your biopsy out to figure out the type of cancer. And then that's how we then know how to treat it. So I'm like, well, I'm not doing chemotherapy because, I don't need to, why would I do that? And there are these other forms of treatment. I was really just not realizing much, just figuring out I could figure this thing out myself. And when I got my stuff back, I was triple negative. So really, there was only one recourse for me, which was the chemotherapy, which I was not really into. But when you added up the cost, when you looked at everything, it was extremely expensive. And that's another thing. Ladies and gentlemen, please make sure you have insurance. If you're working for yourself, if you're not working for a company, go ahead and get self-insured. Ensure that you have something there to help you because it is a cost that is extremely astronomical. And if you don't have savings or if you don't have help, it can be as debilitating as the disease itself. Having to, output all that money for these treatments. So I did my treatment. I did not do my treatment in Jamaica. I went to Dr. Wharf, by the way, great oncologist, as Dr. Smelly is. And she guided me. It was 4 months of chemotherapy for me at stage 2. And I had the option of doing a lumpectomy. But I did not want to do that. I wanted to do a mastectomy. That was a personal choice for me, as I wanted to get, in my head, just get rid of everything that was there. I just wanted it gone. And that was an option for me. And I did my chemotherapy first to shrink the lump. And then I did my mastectomy after that. And then I came back. I didn't do any radiation or anything like that. And then it was just a matter of, following through with the things that you have to do. A lot of what Dr. Smelly spoke about, as well as Dr. Roberts, and just ensuring that you try to stay as best as possible on top of things. And for me, I just really wanted to stress to women that don't fall into the trap of what age are you. I don't think that matters anymore. Don't fall into the trap of, oh, no one in my family has it. I possibly can't get it. That's not true either. Up to last week, I got a call from a client whose coworker is 26 with breast cancer in both breasts. It's just, I don't think it has a radar on, oh, you're white, you're black, you're young, you're old. It doesn't matter. It can affect anybody. And so self-checks, and then as Dr. Smelly and Dr. Roberts talked about, once you're at a particular age 40 and up, ensuring that you have your mammograms annually. But if you have other history, or if you're feeling anything, don't be fearful. And I got that a lot, and I still get it a lot of messages or calls that they're scared. You're scared to go and find out what that answer could possibly be. You're scared to do it because you hear it hurt and it squeezes up your breasts, or you're going to be in pain. But it's better to catch it early and deal with it than wait it out and then have to deal with it after. So that's kind of where I am. I hope I kind of covered everything in a...
Tara, I'd like to ask you a couple questions. Mm-hmm. One, did you seek counseling? And
no.
2, did you change your diet?
Yes and no, because I do cheat. And in the pandemic, as you can see...
When you say change it, what did you change it to?
All right. So I didn't seek counseling. Oh, and that's the other thing I need to talk about. I'm a little weird. So for me, I found it better not to tell a lot of people. I found that for me worked because I didn't want people to be sorry for me. I didn't want people to be calling, oh my God, poor you. I'm not into that. So I continued to work. I didn't tell many people. I just continued to go along, and I find that how you approach things sometimes mentally, whether it's cancer or anything else that you may be dealing with, has a lot to do with it as well. So I just kind of treated it like a project that I needed to go through, and I needed to deal with particular steps, and I would check things off mentally and know that, okay, I do this, do that, and just continue to follow this or that. Diet-wise, we all know that cancer and other diseases live and feed on sugar. So processed foods, whites, flour, rice, anything sweet, soft drink, sugar, candy, all of those things, important to eliminate them from your diet. We're lucky to be in Jamaica where we have a lot of things that are helpful at our fingertips, with which people who live outside of Jamaica sometimes don't have. Soursop leaf, guinea hen weed, all of those great things that we can use as teas and drink, and continue to improve D3 vitamins, ensuring that you have D3 in your diet, getting sunlight, sunshine, which we're lucky to be here as well. All of your vitamins, your C's, turmeric, which we have here handy and readily as well, also very key. So including those things in your diet, eliminating certain things, that doesn't mean that at the end of the day, you're, holed up just eating leaves, but, just try to improve your diet as best as possible. We know, like, sometimes we like to go out and have a couple of drinks. Lean towards alcohol that has less sugar, like vodka, gin, things like that. If you feel like you want to have a drink or do something like that, instead of things like rum or wines that are heavy with sugar as well. So those are the things that I can say from my standpoint.
What would you say was your biggest challenge?
I think for me, when I found out that I was triple negative, that's when I found that most jarring. Because as Dr. Smelly pointed out, when you read up on it, when you find out it is the most aggressive, and it doesn't have an option for a hormone treatment or anything else. So it's just a one-way street. And I found that to be jarring, and I realized that, in checking it out and research, that it tends to be prevalent mainly in women of African descent. So, but then I just tried to look at the bright side of that, which is that once you get past a certain point, the chances of it coming back are less. So I just looked at it that way versus, oh my God, you got the worst of the bunch. So I kind of tried to just look at it in a different way. And I would say, to me, that would have been the most thing. The rest of the stuff, I just kind of focused, really.
If you had three things, three key pieces of advice to any newly diagnosed person out there, what would they be?
Sandy, just let me ask her how, Tara, tell us how you transitioned back after breast cancer.
Well, because I never stopped really doing anything differently, the transition for me was not really a strange one. It was strange in that people are like, oh, what happened to your hair? Or, because I had long hair, and they were like, oh, you cut off your hair. And I was just like, yeah, so I tried not to get into, this is what happened, or, like a woe is me kind of a thing. I really just tried to stay focused. And when I came back, I went and actually just talked to Novia. She's one of the first stops I made, and asked her if I could do, for that month of October, a weekly article just to explain the journey. And so women would not think it couldn't happen to me, because that's how I was thinking. So I wanted women to understand it can happen to anyone. So transition wise, I think just kind of coming out, because most people didn't know, that was a little bit, because people were like, oh my God, I didn't know, But I think otherwise it was fine because I didn't stop doing anything else that I had been doing before. Yeah. And I'm sorry, you have another question, Sandra.
It was the three tips.
Yes, your mental state, approaching it, in a positive mindset. It doesn't mean that it's the end of the world. It's you're gonna die. It's a death sentence. Yes, it is not a great thing to be diagnosed with. Yes, it can mash up your head, mash up your life, mash up your pocket. But stay focused. Keep positive-minded people around you, whether family or friends, and then just continue with your life as you would anyway. That's my thing. I told people, don't treat me any differently. Don't talk to me any differently. If you're going to run joke with me, just run joke with me same way. If we're going to talk about the same things, let's just keep going and doing as we would have any other day. And I think that made a difference. That made a big difference.
Great. Thank you so much, Tara.
No
Rabs, can you just introduce Kevin?
Thank you. Thank you, Tara.
Thank you, guys. Thanks for having me.
You're welcome. Thank you. Thank you. Bless you.
We will now introduce one of our caregivers. This is Mr. Kevin Powell, MBA, Principal of Jamaica Stock Exchange Campus. He's married for 11 years. His beautiful wife, Marsha, Renee, and they have two beautiful daughters, Tavia and Carice. Kevin is an educator, author, motivational coach. He is also a member of the Jamaica Council for Persons with Disability, having been diagnosed from birth with arthrotroposis. You are to tell the word when I finish.
I'll say it's arthrogryposis.
Okay, people. Okay, on national internet. Okay, and a condition that affects his joint, making it difficult for him to walk without aiding a crutch. Mr. Powell had a Bachelor of Arts in English, educator from the University of the West Indies, honor and master in business administration at the University of Commonwealth Caribbean and the Commonwealth of Learning. Mr. Caregiver, Mr. Powell, this is my honor to say welcome, because it's not easy being a caregiver. And I want to be married to you after your because you lose my husband after all of that.
I think Marsha will have a lot to say about that. But
and I love you for that.
But you can have a conversation with her after. I'm sure she don't mind sharing. Right, Marsha?
I know. Tell her I'm her sister.
Okay. Thank you.
Welcome.
Thank you, Sandra. Sandra, my classmate. Thank you for having me. It's really a pleasure to be here to share the experience of the caregiver. When Sandra called, I said yes, easily, because yes, we don't really hear about the stories of the caregiver. We hear a lot about the cancer patient story, but we don't hear about the caregiver. And I think it was a very important part of the process to share that story. And Sandra knows about the story a lot, because Sandra was with me along the journey as well. I had to take my wife to her shop to get her hair cut when she started to do the chemo journey. So she was very much aware. But for us, for me, the process was really a difficult one. We, as everybody has been mentioning, the process started with, of course, the regular lump examination, breast examination. You feel the lump. She felt the lump and she said, "Babes, I feel something in my breast. Touch here, feel it." And I did, and I didn't like what I felt. But like everybody else was explaining, she too, and I along with myself, we were just passing it off. It's your time of the month, and I was doing. I'm the one with the clock and the calendar, so I know. Okay, all right, it's true. It's about this time of the month for real. So you really should be experiencing the hardness and the regular period symptoms. But we just did. It was a lump that was not going away, and so we went to our GP right away, and he was suspicious as well. And he said, "Go and do the mammogram." And we went to the Jamaica Cancer Society to get the mammogram done. And we got it done. When we got back the result, we breathed a sigh of relief, because the result said complex cyst. So our doctor said, all right, he suspected it was a complex cyst. The mammogram confirmed. And as Dr. Robert said earlier, 10% of the time the mammogram and the ultrasound gets it wrong. And I think we were among that 10% because we did an ultrasound right after, because our doctor said, okay, go and do the ultrasound. I'm not convinced that this is a complex cyst, because at this point now the cyst was still there and it felt bigger in our GP's hand. And so we went to do the ultrasound. Ultrasound again confirmed complex cyst, but recommended for us to do a biopsy. And there we were, we did a biopsy. We went to our surgeon, a consultant surgeon at the time, and he said, okay, we're going to do the biopsy. We have to get out the tumor and do it. Did the biopsy, and in March, we got our confirmation that this was breast cancer. At the time, didn't know much. As Tara says, we think that all breast cancers are equal. So, okay, we are saddling up for that journey until my doctor said, the consultant said, we have to do now a IHC. We did the IHC and it came back triple negative. Now, in my head, Sandra and guys, I'm thinking negative means, okay, this must be something good because, yeah, it's a negative diagnosis. Only to hear that this is one of the most aggressive of the cancers. This is one that you're less targeted in terms of treatment because we don't know what's causing the cancer. So the targeting of the treatment is going to be a little bit more difficult. And that was when everything for us kind of just went haywire. For me, as the caregiver now, as a husband, I'm having to play hero, the brave soldier, putting up the brave face, saying everything is going to be all right, knowing very well deep down in the bottom of my heart that I am cowering in fear, anxious, because my wife has now been diagnosed with breast cancer. And cancer is one of those things, I tell you, when the initial news hits you, you are jolted. Like everything that became routine for us was no longer routine. The routine now was regular visits to our consultant. The routine now was, okay, we need to do CT scan, we need to do that, we need to do this, all of these blood tests. That now becomes routine. And so as a caregiver, I had now to kind of recalibrate my mind in terms of how are we going to make sure that every single of these tests are done. If I had to leave work early to pick her up from her workplace to get to the treatment center or to get to the labs or wherever, we had to get it done because we now had to move with urgency, and not to mention the financial bit. Lucky for us, we had our life insurance sorted from about our health insurance about 2 or 3 years prior to this diagnosis. So we were able to wrap back on that. But even with that, the emotional toll, let me tell you, for me, when we were referred now to the oncologist, okay, it's a triple negative diagnosis. We're now to go to the oncologist now for treatment, because as Tara says, the only treatment here is chemotherapy. Chemotherapy is the option, and then we'll take it from there. So we went and we did neoadjuvant treatment to see if they could shrink the breast, the tumor rather, and that the surgeon would get a greater level of clearance to go in. I honestly didn't want to go through chemo. I told our doc, doc, let's get rid of the breast because, for me, in my head, getting rid of the tumor was very important at that point. But the doctor said, let's try this. Let's try to shrink it. And I said, let's go ahead. Now, when I was told all of the things about chemotherapy and what chemotherapy could do to Marsha, Sandra, I sat there and I shook my legs in fear because I'm like, okay, right now my wife is fine. She's, at the point she was healthy, but she was strong. All that was present was a lump in the breast. I'm going to administer chemo now that could perhaps do all of this damage to her cells and that decision was a difficult one for me. It was ultimately hers to make, but as a caregiver, it was just jarring for me to say, okay, this is the route that we're going to go. And then I tell you, I went to work the following day, and Sandra, I bawled. This is the first time she's hearing this. I cried the living daylights out of my eyes at work that day because I'm like, okay, this is it. We are starting this chemotherapy journey. The cancer now became real when we heard that we had to do chemotherapy, and we started that. But then as we went through that journey, and I saw how my wife reacted to the chemo, in terms of, she had limited symptoms. She had the hair loss and she had the nausea, but that was about it. I said, okay, it's not that bad, and all of that. But here's the rubber now. The treatment, at least the first dose of drug that she was getting, wasn't working, wasn't shrinking the tumor. The tumor actually ruptured in the breast, and she had to do emergency mastectomy. Now, that was when, and that was a couple of weeks ago. It was probably like 4 weeks ago, Sandra. I called you and I told you about that. And so I turned idiot. I left I had to leave my home in Spanish Town, rush to the Andrews Memorial Hospital just to get that sorted out. And she had to do the emergency surgery the following day. And she's recovering now. But the journey as a caregiver is an emotional one, because for me, here I was in March thinking we had a clear sense of the direction of where we're going to go with this treatment. But along the way, so many things happened to interrupt that. Along the way, things didn't go as planned. And all the while, you have to remain strong. You have to remain, her buttress in this process, because the moment you feel weak, the moment she sees fear in your eyes, then that is where it gets downhill for her. And one of the things I had to do too was to protect her from people. So I was the conduit. If you want to know anything about what is happening, you have to come through me, because I was protecting her not just from, those, as Tara said, the pity party people, but also the people who had all the answers to all the questions where cancer is concerned. Those who said, drink this, drink that, smoke this, smoke that. I had to protect her from those people. So all of the calls, all of the text messages were channeled through me. I mean, she'd talk to her family members, but the church family and those extended family, I would filter that for her. And I think that certainly did a very good job, I think, for her to kind of not focus too much on this cancer thing. And I was the one who was able to do all of that, in terms of filtering the information for people. What I had to do was every doctor's visit, I did a blog. I did a WhatsApp blog, and I just shoot it to all who were interested. Okay, this was day one of treatment. Here were the signs. Here's what happened. Marsha responded well, and so it eliminated the calls to her, say how was treatment today or whatever. And I think that really helped in getting her that kind of peace of mind to deal with it and to bond more with the family. So we're not survivors, or we're warriors at this point, and we're gonna kick cancer. We believe we're gonna kick it and just kick it out of the curb. But right now, as the journey continues, it's a difficult one. I won't tell you any lies. It's difficult. It's emotionally draining. But I understand that my role is to be there and to make sure that she is protected throughout the process. Her mental health, especially, is protected.
I think there's a point that you made there, and that's why I actually decided to say something. I think it was when you said that you had a lot of persons that became experts and started to tell you, and you should have seen my face and Dr. Smiley's face, because it's something that happens with every single patient that we deal with, obviously more so than others. And it's so sad, because I don't think that those persons really mean anything bad by what they're doing. They're actually just
to help.
But they don't realize that all of those things also have repercussions in terms of how the person who is suffering from the cancer feels. Like they feel like if they make one decision is not in keeping with what the aunt said, then the aunt is going to ostracize them. But then if they don't listen to what the church goes to them, can't go back to church, it can survive this thing in 3 or 4 months. And I don't have everybody else express this. When I see my patients, regardless of public or private, there comes a point where I say to the patient, who's the one person in your family or in your life that you trust when it comes to decision making? And they give me an answer. I say, bring that person with you next week. That's the only person that needs to be involved in your management. So in that case, that person is you, right? And I think you took it up upon yourself to find out all those things so that your wife doesn't have to go through those issues. But a lot of persons don't have that.
Yes.
They don't have that support. So I think that's a valid point that you did raise. The other point that I want to raise, which is something that which is similar, is that you do also have an arm in Jamaica which believes in alternative medicine, right? And it's something. So one of the things, as I was introduced, is that I am the president-elect or vice president of the ASJ, and it's something that really needs to be dealt with. And I'll tell you why it needs to be dealt with. And I'll give you a couple of scenarios. I've had a few patients that have come to me with stage 1 or stage 2 disease, similar to like early stage, don't have any symptoms, just have a lump. It's very easily treatable. Yes, you might have to go through a marathon, of course, but the outcome will be good. There's no ifs or buts unless something drastically changes. The odds are in their favor. And you tell them what they need to do, and they don't believe you, and they go and find some opium man or some person that believes in alternative medicine. And the most important thing about this is that they take their money. This is the most important part of this story,
Yep.
is that they take their money. And when I ask them, and I say, it comes to the point where when I tell them, because I can't tell you what to do, but it comes to a point where I have to, the first doctrine of medicine is to do no harm. But in those conversations, right, in the second part of the doctrine is that you must also protect yourself. And sometimes that comes to the point where you have to now start documenting that you said this to the patient, you told the patient not to do this, but the patient disagrees and the patient has gone about on their own accord. Because what happens in the long run is one of two things. Is that the person doesn't come back and their family member come in their office and ask why you let them go up there because they're dead? Or they come back now with more advanced disease like stage 3, even stage 4, which is in the base untreatable in most cases. And when you ask them how much money did they spend, one person told me that they spent $1.5 million. Right? So you have people who are taking people's money. I don't know what on earth they're giving them, but it's nothing that's clearly been proven or nothing that's being able to help them. So it is a problem in the medical fraternity. Because if Dr. Smiley goes and gives somebody the wrong medication, she can't be sued. Right? You can trace her back to that she gave the wrong medication. You can go and speak to Professor Ward for any other heme college and they say, well, that's not the right medication she should have gotten. That medication is damaging, and that's a problem for Dr. Smiley. But there is no accountability for these individuals.
That's
There's
right.
no accountability. And I think it is something that we have to, because in Caribbean society, we do have alternative thoughts. We do have alternative things, especially more so from persons who come from rural Jamaica than the corporate areas. But the point is just breast cancer affects people from all over. And I think it's something that is an arm of, and this is not only to do with breast cancer, this is other things as well, but it's just that we're talking about breast cancer today. And you brought up that point, so I just wanted to raise that because it's an issue that really needs to be addressed by our fraternity.
Agreed that because I'm sure Carlin and myself, we have met persons who have come to reach the recovery. I mean, and I meet them in general that think it's somebody do them something. And, we just kind of really have to let them know that no, this is what it is, and you have to seek treatment and so forth and so on. So I can so identify with what you are saying because that is our real issue. What I wanted to ask Kevin though, because he does have 2 kids. You gone, Tara? Thank you so much for joining us, Tara.
Bye, Tara.
Bless you. Thank you so much.
Kevin.
Thank you, Tara.
You have 2 kids.
Yeah.
Did you have a conversation with your children, or
we did?
What was your decision?
We did. So the older daughter,
what are their ages?
The one is 19, the other is 10. So the older daughter who wanted to do oncology at UWI but decided against that and started to study medical technology, she was the first one we told, and so she was very, very, very well. Her response to it was a little daunting, but she was more easily pacified by the fact that she's going to trust the science. She says, okay, the chemo treatment is working. Chemo treatment does lots of good to people. Why do you think it's going to do bad to mommy? So she was the logical and clear-headed one in the conversation. But we waited about 2 months before we told our 10-year-old, I wanted to wait because she was still in school. She was about to do final exams for the term, and I didn't want to disturb that. And so at the beginning of the summer break, I told my younger daughter, and she cried and she cried and she cried. But then she wiped the tears and she says, "I'm gonna pray for mommy, and the prayers will work." And we had to have that conversation with her about just what she can do in her capacity as a child now to help mommy to not be so stressed. So it was a good conversation piece to say to her, you have to make sure you do your chores, you have to do this, you have to do that, you have to help mommy now not to be as stressed as this thing can make her. So that was the conversation, and I think we're better for it now. She's at a good place now. I think the last time she broke was where mommy had to do that emergency surgery.
Right.
She was like, "Oh my gosh, this thing has come up again." Because as I said before, prior to the emergency surgery, her mom was doing fine with the chemo. Even when her mom started to lose her hair, it wasn't as jolting to her as when she was told, "No, mom has to do this mastectomy. It's emergency." And so so she cried that time. And again, she just, I guess, I suppose, seeing her mom and that her mom was doing well after surgery kind of helped to pacify her further. But I think it's going to be a constant kind of check on her to ensure that she's fine throughout the process. Our big daughter is being very supportive. She's one of the persons now who has to do the errands with mom, to the doctor visits, the lab visits now because of work obligations sometimes for me. So she's offering that level of support as well.
So
And
for
are you taking care of yourself?
Oh, sorry. I was about to ask you that.
Yes, well, I try to. So post surgery, my wife went to stay with her mom for the last 3 weeks or 4 weeks. She's been with her mom, and I think that was a little bit helpful for me to give me a bit of breathing room to just kind of get back into that place of finding myself, getting back in my writing in mold, and so I'm trying to deal with me as best as I can. I don't know what that looks like because I'm not really sick, but I get the point though that I need to take care of my mental health, and I think the time away that she, not another caregiver was with her, I think kind of helped me to get a little breathing room as well.
I think what we need to point out here is that we often underestimate what happens to our caregivers. We focus on the patient, and sometimes we're not conscious of the stress that is related to the caregivers because they see the problem, but there's nothing that they can do. There's
Yes.
a feeling of total impotence.
Helplessness.
There's nothing that
Helplessness.
you can do.
Yes. That is so true. And for me, the stress also came with just what is the end game, when will this be over, when not knowing when it will be over, and just as you say, Lady Graham, feeling so helpless in the process, because what can you really do than just be there, really? And you feel, a lot of the times feel helpless, like when she started to feel pains and stuff, I'd be like, okay, what can I do? There's not much that I could do at the time. So there's that as well.
So give me three pieces of recommendations, having gone through this experience. Speak to another caregiver out there, or someone who may become a caregiver in the future. What is some of the advice that you would give them?
I think the first advice, and I'll start here as the last point that was made: take care of yourself first, because as they say when you're flying on a plane, put on your oxygen mask before you assist somebody else. Yeah, I think that's important for you to make sure that you get bolstered in the fact that, all right, you are the one who's going to be carrying the heavy load here. You have to accept that. And I have accepted that I am going to be her buttress. I'm going to be her fortress in this time. So you have to see that and understand that. And secondly, provide not just the physical support, but also provide the emotional support. Sandra, I was there when she was sitting in that chair of yours, and you were the one to cut her hair. That was a big thing for her. That was when it became palpable, I have the cancer and my hair is going, my hair is gone. And I had to be there that day, along with other friends, just comforting her. Sandra, you remember we were in the car park for a while because Marsha had a meltdown that day because her hair is now gone. And I couldn't rush her and say, we are crying for or we are hurt, let's go. No, I had to pause, forget about the whatever exigence that we had at the time. So this is the moment that you have to be there for her. So emotional support is very, 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 very important, as well as get involved. There's an entire community that you can also leverage the support from. I don't have to feel right now that I am the be all and end all to the support. I have my parents, she has her parents, our children are there to support, our extended, our church family has been tremendous. Like there are times when I will say to my church family, listen, I can't make it to chemo today. Can somebody come and pick up Marsha? Because everybody's gonna call and say, tell me what I can do to help you, please, please, please. So I say, you're going to put your money where your mouth is now. I'm going to call upon you to come and pick her up because I need somebody to pick her up at the doctor. I need somebody to pick her to take her to the lab. I need somebody to take her to get her medication, So leverage the support from the community as well. And I'll give this advice to the caregiver as well. As a fourth one, help to be that filter. I think that was perfect for me, to be that filter, that information filter, that people filter, and that just be that filter to overall for the patient.
You're doing a good job.
Yes. Yes, he is. He really is a strong, well, that's his personality too, His personality is that kind of take charge kind of guy, and he gets things done. So that is his personality. So he really is
and I must say, Sandra, some good has come out of this, because over the last 4 weeks, I've learned to cook. Prior to this cancer thing, my wife is the chef in the house. Because of the fact that I have to now take care of her, and she's no longer around, I have to cook. I learned to cook rice and peas and chicken the first week. Today's menu was chicken Alfredo and chicken and shrimp Alfredo.
And everybody's alive and well.
Everybody's alive.
I have to add something to it though, because when I went through my chemo and my everything, I have 3 sons and they were young, and I've had it for a long time. So we started when my youngest was about 6 or 7. And what I think has happened to my children is positive, because if they have a wife or a girlfriend who goes through my experience, I know they can cope, because they have helped me to cope with chemotherapy. They've helped me to cope with the radiation. They've helped me to cope with pain. They've lifted me in the hospital bed when I was weak, and they will be able to manage this disease in a wife or a girlfriend or a partner. So that is one positive thing, if you can call that positive.
Yes.
Yeah.
I can attest to that one.
Yes, having mentioned the losing of the hair and how traumatic it is, I know we have 2 persons online, both Jennifer, who does hair replacement, and Althea, who is a trichologist, about can we just say a little bit about not worrying about the hair, because lots can be done about the hair situation, and it does grow back. I was bald as a baby bottom, and it grew back. So can you both say something about the hair situation? You want to go first, Althea?
Okay, Sandy. I know it will grow back, but some persons are attached to their hair. Okay, but you have to also remind them that is one of the first things that the medication will take. Is one of the fastest growing cells in the body, but is one of the first to always go. So if you find a client who is so attached, because when I started chemo, I think about using a cold cap during chemo, and I'm like, why are you doing that? You don't even like combing your hair. Mm-hmm. Okay, so I had that conversation with self, and I said, okay, how am I going to do this? And how I did it, I had some friends who convinced me to have a shaved head party. And you know, Wayne had his hair for about 20 years, and he said, I will join you to shave my head when you're shaving yours. And I did that for me. And I wasn't a person who was attached to hair. Okay. But I have persons who was going through chemo, younger than I am by far, who had issues where I had to really sit her down and really counsel her and say to her, listen, it is going to grow back. This is how it's going to grow back. And we will just have to take it from there. But Sandy and everyone, a lot of person out there, the first thing that they said, I am attached to my hair. And I can really and truly understand from that point of view. But it will grow back, and Doc will tell you, because if it's not, Dr. Alexander, if it's not the chemo, sometimes different form of hormone in the body will take away the hair. Like the dihydrotestosterone hormone that leading into female pattern baldness. Okay, so with all that said, Dr. Alexander, tell me, what are some of the problems that you find with women who resisted chemo from hair loss?
Yeah, well, I have nothing more to add really, because as you say, it grows back. It does grow back. It's just a period of the waiting and the anxiety and the stress that you have to deal with until it grows back. So I really don't offer any service. I just say, you know, take your vitamins, take your this, take your that. It will help your hair to grow. I can tell you something. My mom had COVID and all her hair fell off.
What?
And you know, yes, she's almost still bald, but you know what has helped her? A thing called Beaker zinc, B complex, and vitamin C. And it's helping her hair to grow back.
By any chance, do you have any of those hair strands, Doc?
Any what?
Any of those hair strands from your mom?
Any of the hair strands. If you have any of the hair strands, I guess she wants to do an analysis.
A mineral analysis test on that hair. Yeah. Because I am.
No, man, no. By the time she came out of hospital, most of it had gone. Really and truly.
Wow.
So, but I'm confident it's coming back. It will grow back, just like in breast cancer. Once the chemotherapy is over, it gets out of your system. It's very exciting to see new hair come back, and it's something to look forward to.
But what I found out when I lost my hair, for me, and I have clients who I know do that treatment, hydration treatment. When I was going through the chemo, my skin gets so thin and my scalp gets so dry that I feel like my scalp was going to just break open. And what I did from my study, I went in and I rehydrated my scalp with rehydration salt. And then I go underneath the rehydration machine, but I have to put like a wet, cold towel on my head because I couldn't take the steam from the hydration machine. So to really and truly hydrated my scalp because I couldn't lay on the pillow at night.
That tender.
Because it was that tender.
We have some questions that we want to take from the audience. They were asking, why is the chemotherapy and the radiotherapy so expensive? Those were some of the early questions.
Well, I mean, for one, we live on an island. We live on an island, which means all of those medications have to be imported. And I think I want to take a moment to kind of applaud the NHF because they work really hard to make sure that the medications are here, that they're available, that they're accessible, and they're as affordable as they can make them. But we have to remember that everything that we use to treat has to be brought into the island. And so that's going to obviously affect the cost. And that's another reason, aside from having your health insurance, you should make sure you have your NHF card because the most common medications that we use, for the most part, are subsidized by the NHF. So even if you're getting private care, you can use your NHF card alongside your insurance to reduce the cost, your out-of-pocket costs of your medications. So it's very important that you have that card. And the NHF card can also be used to pay for your IHC tests. If your IHC is done at the university hospital, you can swipe the NHF card and it takes about 50% of the cost of doing the IHC, which is the test that tells you if it's hormone sensitive or not. So NHF all the way.
That's excellent information. Is there a timeline to have chemo and radiation treatment done?
That is a really individual decision. And so, as Dr. Roberts was saying before, usually it's a collaboration between the oncologist and the surgeon about what is the best approach to taking care of this particular breast cancer. And so that will determine, are you most likely to benefit from doing your chemotherapy first, then your surgery, then your radiation afterwards, if it is indicated, or are you going to have surgery first, etc. Usually between the end of, if you do chemotherapy first, it's about 4 weeks between the end of chemotherapy and surgery, if that's the order you're doing it in. If you do surgery first, then you usually have to recover from your surgery. And so it's about 4 weeks after the surgery that you will start your chemotherapy. And then once you have completed chemotherapy, we usually try to get you assessed by the radiation oncologist within that last month of treatment. They'll do their initial assessment so that they can discuss the timeline for starting radiation if it is appropriate.
Okay, thank you. Kevin, they said you deserve an award. Kudos to both of you.
Yep.
Did you and Marsha have that discussion to have others help out in that way?
No, believe me, we didn't have time to have any discussion at all. Everything just happened so fast. But I think once persons knew what was happening, they started to help. You know, the help was spontaneous, really. And as I said, I just had to be that point person, that go between, to say, okay, what's the nature of the help that we need, and when do we need that help? Because lots of people were willing to help, but at the time, we weren't ready for the help at the point. So I'd say to them, all right, not right now. I have it covered until week 3, but I'm going to need somebody to fill in for me by week 4, week 5, week 6. So we had to coordinate that after we realized what was happening and the gravity of the situation.
Okay. Doc, how long does the hair take to grow back? You can
Me
take
or
it,
Dr. Bambi?
Which one? Whichever. Who has that experience? Who has the experience with the hair growth? Right, Dr. Alexander.
Okay, so I lost all my hair, everything, eyebrows, eyelashes, head, the whole works. And I think I noticed it about, and my chemotherapy was for 9 months.
Wow.
I noticed my hair, I noticed fuzz on my scalp 3 months after my chemotherapy stopped.
Okay.
And then
I kind of had a similar,
yes,
I kind of have a similar experience, but what I noticed is that it kind of, some little sprinklings kind of grow up as you finish, but you have to keep on cutting it for it to fill in, because it doesn't grow back full. So it grows back sparse. And so I just, in order not to look sick, I kept on shaving it off until it kind of filled in.
It comes back soft.
Timeline.
Yeah, the quality is different. It's soft.
Right.
It's different from what you had before.
Right.
And then it changes character and you start to get back your regular hair again.
Right. Yvonne says, when I saw the first falling, I went to the barber, but I was accustomed to keeping my hair short. My hair is now growing back, so she's agreeing. If I get private care but require Herceptin, will I be able to access it at one of the 3 hospitals mentioned?
So the hospitals that have it are government hospitals, which means you are entitled to access care that you need at a government hospital. So Whether or not they will have enough to enroll you on the program is a different issue, because they can only treat a certain amount of patients per year. But in terms of will we send the referral? Absolutely.
Okay, great. Is there a wait time between the last chemo treatment and radiation?
On average, if you're getting treated on time, it's about 4 weeks, because most of the chemo that we use, it's most active within the first 2 weeks of your treatment. That's when you feel sick. That's when you feel weak. If you're going to have side effects, that's usually when you'll feel them. By the 3rd week, it's generally most of it's out of your system. And so usually by the 4th week is when a new intervention, be that radiation, be that surgery, that's usually the timing for it.
Dr. Alexander, I didn't ask, do you have any statistics, like age group? You find that more older persons are getting breast cancer now, or you're seeing more younger persons middle age. You have any kind of stats?
I don't,
even
but
not?
I can tell you in my own database, I found when I got my breast cancer, more persons were being diagnosed after the age of 50. But I'm thinking it is because screening was taking place later.
Get you.
So
So now you're finding a lot more young people.
Young people, younger. In fact, even late 20s, 1 or 2, mid 30s, late 30s. And I don't know if it's because, I think it's probably because screening is starting earlier. People are just more aware because of your program, Cancer Society. People are now going to get mammograms, they're going for examinations, they're going for ultrasounds, and they're not waiting until after 45 to go. When it's too late, it's stage 2, stage 3.
Okay.
That's my experience.
Dr. Roberts,
Can
when would somebody be required to remove both of their breasts?
So that procedure is referred to as a bilateral mastectomy, and usually that procedure is referred to as a bilateral mastectomy.
Yes.
And there are different scenarios. So you can have actually mastectomy done on the affected side, and there are different types of mastectomies that can be done, taking into consideration whether or not you have reconstructive surgery. And then at the same sitting, you may decide to have the other breast removed to reduce your risk. So there are 2 instances. You can either have both breasts removed when you don't have any cancer, but you've been deemed high risk because you have genetic testing done, or you have a very strong family history. A perfect example of that in society is Angelina Jolie. Right. The other example could be that you had breast cancer at an early age in your 20s or 30s. You had genetic testing done which shows that you are still high risk. And one of the risk reducing measures that you have is to reduce the breast in the other side so that you don't want to go through your life worrying about developing breast cancer. No, one thing that must be said, when you do remove your breasts, the risk does not go down to 0. The risk just significantly reduces. So it's a conversation that you actually have with your surgeon, because as Dr. Smiley, I'm not sure if she mentioned it here because there are actually 2 breast cancer talks I did today. But the risk, in terms of risk reduction practices, they can be broken down into 3 elements. One is surgical, which is removing the breast. The other one is medical oncology, which is where you can give different drugs to help to reduce the risk of development of breast cancer. And then the third one is where you just increase the amount of surveillance that you do. So for me, it's always on an individualized platform. I have performed that surgery numerous times on patients. But the first thing I have to make patients realize is that removing your breast does not remove your risk to 0. Right? But it's usually in patients who have a significantly higher risk of developing. So for example, if you had a genetic mutation like the BRCA1 gene, that means that your lifetime risk of cancer is between 60 and 80%. Whereas an average woman, her lifetime risk of breast cancer is around 8 to 12%. So you can see the vast difference.
Do we offer that test out here? The BRCA?
Yeah, it's genetic testing. So you can take the swabs here and you can send them to labs overseas. The majority of labs that we use are in Southern Florida, in Miami, Fort Lauderdale area that we use. The one that I tend to use most of the time is a lab called Color that I'm sure Dr. Smiley is familiar with. And what they do is they don't only test for BRCA1 or BRCA2. There are other genes that they test for. There's actually like a 17 gene panel that they test for. So but one thing I must also mention to you, if you do come back with a genetic test that's negative, it doesn't mean that you don't have a genetic mutation. It just means that you don't have a genetic mutation of the 17 common genes that are tested for. Because you could still have a strong family history that's suggestive that you have a genetic or familial predisposition. So those patients should still be treated as high risk and should still be offered the options for high risk patients in terms of risk reduction. The important thing is if you do have a bilateral prophylactic mastectomy or a prophylactic mastectomy on one side, if you do have breast cancer, that person should also be considered about the risk about reconstructive options. So reconstructive surgery can actually be done for those patients. So that after they've had their breast removed, they already look like they didn't have anything removed unless somebody actually takes their clothes off. And we're not going into that conversation clearly. But they at least would still feel physiologically acceptable because socially acceptable because they still have a new breast being formed.
Right.
And in the case of both breasts being removed, one of the good things is that the synergy or how the breasts look compared to each other actually more appears the same, similar, as opposed to when you only remove one breast and reconstruct one breast.
Well, what I can tell you about my situation, I only remove one breast, and I'm not a brassiere person. What I found is that because I did not do reconstruction, the rib moved up in the space, so my spine is now curved because the weight is not there on the chest. So what I now have to be having treatment for my back because I now have a curvature because the rib came up. I suppose like when your teeth shift, my rib came up in my space because I don't really wear a bra at all.
So I mean I just want to ask you a question. How long ago were you diagnosed with breast cancer?
22 years.
Right. So as Dr. Mambi said, because I think she said 30-something years for her, breast cancer treatment has evolved completely over the last 10, 15 years. Right? I don't think there's any surgeon that practices breast cancer now that's going to offer a patient mastectomy without some form of reconstructive consultation.
Well, I was going to do reconstructive surgery, but what happened? I was 35, and they had to radiate the area. And what happened? So they did I didn't do the reconstructive immediately. So when I was finished and they staged and they checked and they did everything, they said, well, we don't want recurrence, so you'll have to do radiotherapy on the area. And so because they had to remove nodes and four of the 14 nodes were positive, so they had to radiate the area because I wanted to do the expander type reconstructive.
So again,
and once the area is radiated, it can't stretch again.
But that's
and I didn't want to do the tummy flap.
Right. So that's not true anymore. Right. So
okay.
So you can have what is known as immediate or delayed reconstruction, and the most common reason for delayed reconstruction is what you just said, that you want to radiate the area because radiation can lead to deformity.
Right.
So once radiation is finished, you can actually place an expander in now, and there are techniques that you can. You'll slowly increase. Once you put pressure on an area, it's going to naturally stretch. The expander is no different from me telling you to drink 10 Cokes a day and you'll see how your belly stretches after a while.
Darling, we can't tell about the belly stretch.
Right, so it's that you are manually doing it as opposed to physiologically or pathologically doing it in terms of putting on fat. Your skin will stretch once your skin has the ability to stretch. So that's what the expander is for. It may take a longer time. I'm not going too much into this round because this is more so the plastic surgeon's area.
Right.
But there are patients that we've radiated their chest wall. Similar situation, you have significant nodes positive. And 2-3 months later, we just operate on them and put in an expander, and they do have an implant placed. I think the difference is, not to go into detail, is where you place that implant. So a lot of times, you can't put the implant under the muscle, you have to put it over the muscle. So you can't put it what we call subpectoral. You might have to put it on top of the muscle.
Okay, that is excellent information. Anna says, what will happen if a person who is at stage 3 plus, who have who has who have done all the chemo but haven't gone through radiotherapy?
So again, you're talking about a patient who's undergone neoadjuvant therapy, meaning they got chemotherapy before surgery. All right.
Sorry?
So in that situation, as Dr. Smiley will tell you, it's not the same way how there are different types of breast cancer. There are different types of chemotherapeutic drugs and regimes that you can give the patients. So, and again, it's communication between the hemoncologist, which is her, and the surgeon. So it's not that I send the patient blindly to her to get chemotherapy, and then after 6 cycles or 8 cycles, she sends the patient back to me. Usually there's a review process to see if the actual treatment is working, and if it's not working, you can change the treatment or you can add different drugs. Now, then, will I do it well so far? Okay,
Yeah.
great. Right?
Sharon is saying,
Yeah,
can you get breast cancer again in the other breast? Well, I would say that would be a yes.
Yeah, one of the biggest
And
risks of
having breast cancer, or which other type of cancer is the most likely to get? I guess what she's asking, if you can have a spread or a recurrence in the other breast.
So it's not necessarily a spread, it's what we call contralateral breast cancer development. It's actually a new tumor. And that's usually because a risk of breast cancer increases your risk for another breast cancer in the other breast.
Okay.
And that drug that Dr. Smiley was talking about, or those groups of drugs, which he called tamoxifen, is one. That's one of the benefits of tamoxifen, which is given in hormonal positive women. Women whose breast has evidence of estrogen or progesterone receptors being positive. The reason why you give the tamoxifen or the aromatase inhibitor, depending on whether the patient is pre or postmenopausal, one of the benefits is to reduce the risk of contralateral breast cancer. And that risk is going to be as high as almost 50% in some cases.
So break that down a little bit more for me, Doc, because I remove both breasts. Okay.
So you remove both breasts at the same time you had surgery.
At the same time, and
right. So that helps you to reduce your risk of developing breast cancer in your other breast later on.
Yes.
But your risk is still not down to 0. So if you did come back being estrogen, were you triple negative or you were ER positive?
Positive.
Right. So you were still, I don't want to ask your age, but you would still be on some kind of hormonal therapy.
I am. For the last 8 years, I am on.
Right. And that hormonal therapy is not only to still reduce the risk on the other breasts, but it helps to reduce the recurrence rate on your breast that you actually had the cancer in. Now, if you've gone 8 years, that risk is significantly reduced because, as Dr. Smiley will tell you, as every year passes, after year 2 or year 3, the risk significantly reduces down to tends towards 0. But as she rightfully said, the use of those drugs used to be up for 5 years. And that's mainly because we used to look at the side effects to benefit profile. But they're actually showing you that if you continue from a little bit longer, there's still a benefit from continuing the drugs closer to 10 years.
So it has to be, because you don't know the amount of side effects that I've gotten from this tamoxifen.
Yeah.
Okay?
Right.
So each time I go to put one in my mouth, I say, Lord, bless this tablet.
So I'm glad that you mentioned that, because anytime somebody tells you to take tamoxifen, and that's anything in medicine, there's always a risk to benefit ratio, right? In tamoxifen, the biggest risk obviously being you getting clots in your legs. You also getting your uterine lining getting larger, which is a predisposal for
early menopause,
endometrial cancer, all of those different things, early cataract, ophthalmia, all of those things that you need to be aware of.
See?
Yeah, so there are right. So there.
You have to forgive me. I took myself off after 2 years.
So there are a lot of risks that you can have. What some people may do, Dr. Smiley, correct me if I'm wrong. Once you actually go into menopausal age, some people actually switch from the tamoxifen to the aromatase inhibitor so that you can get.
I did. We switched for 1 year, but the amount of joint pain.
Yeah.
That's why I came off.
I said to Dr. Wolf, please do not write me another prescription. I'm going back to tamoxifen because at least I can deal with the mood swing, the depression, and I know to stay home when I'm having those. But the joint pain, and I walk 5 times a week, okay? I have to walk to release those pain. It was crazy. I could feel my bone it's like they were just breaking down.
So I bet you I know what doctor works. She switched you back to tamoxifen, right?
Yes.
So that goes back to the same thing I mentioned to you about half an hour ago about having a discussion with your doctor. So
Yes.
your case might be extreme in terms of the orthopedic complications or the bone complications, and it's a simple discussion with your doctor to change back the medication.
Yes.
So even though the complications are listed, not everybody's going to get the same complications, the same frequency or the same severity. And yours is unfortunate that you had severe complications when you switched to the aromatase inhibitor. But the point is that there were still alternative things that you could have done where you could have switched back to the tamoxifen.
I was taking all those alternative things with the aromatherapy, whatever you call that drug. I never learned the name. Excuse me. I learned tamoxifen. Okay, never learned that one because I couldn't be sitting down here crossing my leg like this talking to you so comfortable. I would be in pain.
But what I would say to you is though, and this is more so towards what the point that don't think I didn't hear what Sandra said. How she never stopped. She stopped taking the medication. The risk of the medication does outweigh the benefits. And it was back to a point that Kevin made earlier too, where he said, "Boy, my wife is fine. You know, I mean, she have a tumor, but she look good. She feels good. She not in pain. Why should I now send her on chemotherapy? Because at the end of the day, myself and Dr. Smelly knows what the end results look like. And one thing, unfortunately, about medicine is I can't go back in time and change what happens. Right? A lawyer could at least tear up a piece of paper and write it over again. Accountant can switch some figures and change some stuff. Once you do not embark on treatment, I've lost that time. And many things can happen during that time. And we know what the end result at that time can look like. And a lot of times it comes down to having trust with your doctor, your team of doctors.
Yep.
Well,
and I want to add to that actually, because that's really, really important. A lot of people, when they come into the office and you have to say to them, hey, you know, I think that for your case, some chemotherapy would be the best thing for us to start with in terms of reducing your risk and so on. And then they disappear and, you know, they go to these alternative practitioners. That is time lost that we can't get back when you are taking, and I say this as someone who has nothing against green juice. Green juice is great, but what we have to do is recognize that what we are offering you is something that we have evidence for. I can pull the studies, I can pull the data, I can pull other patients that I have treated, and I can say to you, this is the most likely outcome. This is what we're aiming to get to. But fear, preconceived notions, the opinions of, you know, well-meaning community oncologists who don't treat cancer but have lots of opinions on how to treat cancer often influence the decisions that people make. And all of that amounts to time lost. And what people need to recognize is not just that it's not a death sentence from the get-go, but it's also not a death sentence at stage 4. Right? There's lots of treatments for stage 4 breast cancer. But the question that you have to ask yourself is, do I want to risk living with stage 4 breast cancer? Like stage 1, 2, and 3 are not cheap. Stage 4 is not cheap. Ongoing treatment is not cheap. It's not cheap on your pocket. It's not cheap emotionally. It's not cheap spiritually. It's a lot to go through. So when you are at the beginning of your treatment, you have to consider not just the short-term ramifications of your decisions, but the long-term ramifications of your decisions. And what do you want to potentially live with, and what do you want your quality of life to be like? And what are you willing to do to try to get the quality of life that you want?
Sandra, if I may, I probably want to do a follow-up question with Dr. Smelly and perhaps Dr. Roberts here, because one of the things that we have had to struggle with was a decision about whether we do neoadjuvant versus just mastectomy at the beginning. Of course, we went the route of doing neoadjuvant, and a question was being asked by Narda, which is perhaps perhaps, instructive of the neoadjuvant is, how do you know if the chemo is working if you haven't already done a mastectomy? And I probably, at this point, it's still not resolved to me, because I'm thinking perhaps if we had done the mastectomy a lot sooner, perhaps we wouldn't have had an emergency mastectomy. But then, as we are now being consoled, we also would know which drug type of chemo her cancer doesn't react to. Right. So what are your thoughts on that?
So that's one of the big advantages of doing chemotherapy before your surgery, of doing a neoadjuvant path, is that it allows you to assess objectively the response of the cancer to the treatment, because either the lump gets smaller or it doesn't. It also means that at surgery, you can be assessed for something called a pathologic response, which Dr. Roberts mentioned before, which means that the pathologist, Dr. Mamby, can look at the breast underneath the microscope and say, okay, there is still evidence of cancer in this breast, or actually, no, there's no longer any evidence of cancer in this breast, which is our best case scenario. Like, that's what we're aiming for. And then knowing whether or not you're able to completely eradicate the cancer before surgery means that once you've had surgery and you know what the outcome is, you can say, well, your chemo's worked really well. We can now move on to other forms of care, or we can say, actually, there was a little bit of cancer left. And depending on the type of breast cancer you have, we can have another discussion about whether or not there's a benefit to additional medications to reduce the risk of it coming back now that it has been physically removed. If you have surgery first, then you don't have the advantage of knowing for sure that the chemo that you get is definitely going to affect the cancer cells that may still be in your body. What we're doing there is sort of statistically, we're saying, okay, we know these drugs are the most active. We know these drugs are the most appropriate for the type of breast cancer that you have. And therefore, we know that these are the likely outcomes of treatment. And so therefore, this is the path that we are advising based on your specific cancer type, based on the type, your health conditions, what can you tolerate versus not tolerate. And we individualize a treatment plan based on what we think is most likely to work for you.
Let me ask this question. So after you finish, you have gotten all of your treatments, there is any recommendation of a PET scan, or what do you recommend to continue to follow up, like years after a bone scan, MRI? When do you introduce those scans to the patient?
So I love that question. Yeah, I love that question so much.
I'm always, what am I going to do a next scan?
That's a really common question, and I'm glad you asked it, because the NCCN, which is the National Cancer Comprehensive Network, that's one of the sets of guidelines that we use to decide treatment.
Don't let
there is actually that's one we all use. But they actually, once you reach surveillance, which is you've done all of your active treatments, you've had surgery, you've had chemo, you've had radiation, etc., you're now just being monitored actively. There is no benefit to doing a regular CT scan like every year. There's no added benefit to it, doing a bone scan every year, because it does not detect recurrent disease earlier than if you just wait to have symptoms that need to be investigated. So what they have found is that doing a CT scan every year costs you money, exposes you to radiation, and doesn't detect recurrent disease earlier than if you just wait for something to happen. So what we do in active surveillance is an annual mammogram, because that other breast is at risk. That other breast has to be monitored carefully. But doing a CT scan or a bone scan on an annual basis, it might help your brain feel better, but it doesn't actually help your body do better in the long run. It doesn't change the decisions that we make. And so I tell patients up front, nope, we are not going to be doing a CT scan to check. If you have a symptom, we will absolutely check it out. If something happens between your visits, call me, come into the office. We will do a checkup. I will examine you, and then we will determine what the most appropriate thing to do for your symptoms is. But an annual CT, an annual PET scan, an annual bone scan don't actually have the benefit that you think they do.
I think you have to recognize, Althea, is that Dr. Smiley made this point. earlier on. When you're giving patients chemotherapy for cure, there's no evidence of disease anywhere else in the body. What you're actually doing is using, as she said, statistical data from the pathological report and the immunohistochemistry to say, well, this tumor might be a little bit aggressive. So there's a possibility that there's what we call micrometastases around the body. And a micrometastasis is basically anything that's less than 0.2 millimeters. And why I'm using that measurement is because it's so small that it cannot be picked up by any radiological instrument known to man. Once you pick up something that's no longer micrometastases, that's like you have stage 4 disease, that's metastatic disease. So what they may do before you start chemotherapy, which is what Dr. Smiley does as well, is that they're going to send you for staging investigations, like the CT scan and the bone scan and those things, because they want to make sure that you fall into that curative group of stage 1, stage 2, or stage 3 disease, as opposed to metastatic disease. And then based on the pathological specimen, the IHC and all of those things, she's going to come up with a chemotherapeutic regime that she's going to give to you. Now, if it is that you are living like Sandra or like Jennifer or whoever else is here, you have to ask yourself, is it that the chemotherapy worked or was there nothing really there? You don't know. You can't answer that question fully. So what you are basically doing is just assessing the patient for surveillance to see that no contralateral breast cancer is going to develop, or breast cancer at the same breast if it is that you had a lumpectomy done alone. And you want to reassess the examination, the site where the breast was removed, just to make sure that there's no recurrence there. And if there's something, then it will require further investigation. But follow-up is usually just clinical examination, obviously asking how you're feeling and how you're doing, as well as sending you for your annual mammogram.
Boy, that time, long time, but boy, the information is really rolling in and the questions are really rolling in. So let me just take the questions quickly. Any suggestions on how to prevent lymphedema?
It's not really that something that, well, it starts before it can occur. So it occurs mainly when you do a drastic lymph node dissection. And by drastic mean anything more than what we call level 2. So the way how the axilla is divided into 3 levels. Level 1 is the nodes that are below the muscle, which is pectoralis minor. Level 2 are those that are behind, and level 3 are those that are above. Usually when we do an axillary lymph node dissection, we take level 1 and level 2. Now, newer techniques are available for patients to help to also reduce lymphedema. So, for example, in patients who clinically don't have any nodes, which means that when you examine them, you don't feel anything, and when you probably do the ultrasound or even the MRI, you don't see anything under the armpit. Those are patients that are actually subjected to sentinel lymph node biopsy, which is a less morbid procedure. Care for the section, as I said, and a big part to reduce lymphedema is physiotherapy.
Isn't there a test that is used with dye?
Yeah, that's the sentinel lymph node biopsy.
Okay.
Sentinel lymph node biopsy, and it can use either dye, which is a blue dye, which is known as isosulfan blue. We tend to use something a little bit cheaper and more available.
We do it out here?
Yeah, man, we do it at KC in private practice at university. You use sterile methylene blue, and you inject it around the lump or under the nipple areola complex, and then you look for that blue dye in the axilla like 15 minutes to half an hour later. But what you're doing is just looking for that one group of nodes to see if there's tumor in them, as opposed to actually dissecting out all of the nodes at level 1 or level 2. So it's usually reserved for those patients who are what we call clinically node negative, which means you don't palpate or you don't see any nodes or any radiological investigations. The other way, if you do have to subject the patient to axillary lymph node dissection, is careful dissection. Make sure you only take the level 2 nodes. And you also make sure that you offer the patient good physiotherapy, which should start before the patient has surgery.
Okay. Is chemotherapy recommended for triple negative breast cancer after 14 years?
How you mean after 14 years?
I don't know if there's a recurrence. Barbara Boyd, is there a recurrence? Maybe she needs to say something. So what's the difference? All right, so since there's no clarity, let us take the next question. What is the difference between stage 1B and stage 2 cancer?
So stage 1B cancer is when you have a T stage of, well, stage 1B basically means you don't have any nodes. So it could either be a cancer that is carcinoma in situ, or what we call as a lump that weighs less than 1 centimeter, less than 2 centimeters in diameter, but there are no nodes at all. Stage 2, there's nodal involvement. That nodal involvement usually spends to the first set. It usually means that the nodes are mobile.
Okay.
Yeah.
They if you are not on any medication after 24 years, are you considered cured?
I would think so. I would hope.
You're still
I mean, you still have to undergo
Limbo.
Risk
surgery.
is really low. Your risk of relapse at 24 years is really, really low, but it depends on the type of breast cancer that you had. So if you are hormone positive, then your risk of relapse at 10 and 20 years after your initial cancer is still somewhere between like 0 and 10%. It's small, it's tiny, but it's not zero. If you're triple negative or HER2 positive and you're 20 years post your initial thing, then it's almost zero, because the risk is really highest in those first 2 to 3 years. And by the time you get to 10 years, it's really close to zero. So it depends on your breast cancer type. But if you have no symptoms and you feel great, then we're happy to be like, continue living your life.
Okay. Miss Boyd responded. Oh, you wanted to leave, Caroline?
Yeah.
I see you waving.
Yes.
Oh, yes, you have another meeting, right?
Yes, I do.
Okay, all right.
But it
So you
was
want
really
to say
great
bye-bye?
to hear you. Bye.
Okay, bye, Caroline. Thank you so much.
You so much. It's been really, really informative. And I'm sure everybody who's listening is learning a lot. Reach to Recovery thanks you. Bye.
Bye, Caroline. Miss Boyd did respond. She said, yes, it's a recurrence.
Oh, once there's evidence of disease, it needs to be treated.
No, what she was asking was, is chemotherapy still make sense after 14 years?
There's disease now. So if it's recurred after 14 years, then there's disease now and it needs to be dealt with.
It says 14 years after the first diagnosis, which is with a stage 2 breast. Stage 2.
Let me just be more specific. Is it in the same breast that she had the tumor in, or is it in the other breast?
In the other breast, yeah.
In the other, what did she say? She said,
because I would say if it's in the other breast.
She didn't say. I guess she'll answer.
Well,
is it the other breast, Barbara, or it's the same breast? Did you remove the breast, or did you do a lumpectomy?
Yeah.
Because you have to still evaluate that tumor to see if actually it's a recurrence or if it's actually a new tumor.
New tumor.
Yeah.
Right. So it still has to be investigated. And but to answer that to the point Dr. Smiley made, the chances are you're going to still need some form of chemotherapy.
Yep.
Okay.
After it's reevaluated.
Yep.
And so that people know, I was going to ask Caroline to say something, but since she's gone, for those persons who did not do reconstruction, Jamaica Reach to Recovery, they sell the breast form, and they sell bras, the specialized bras that you put the breast form in so that you are balanced. So you don't need to go one-sided. It's not necessary. If you did not do reconstruction, we do sell the breast form at 16 Lady Musgrave Road. So you can always call the desk, as she said before. I will put up the number at the end of the program so that you are aware. You can call for information with regards to specialized bras and the breast forms. She said, Barbara says, not in breast, but in bone. Yeah, Dr. Smelly?
Okay.
Yeah, so
if not in breast, but in bone.
If what is currently affecting
she had a lumpectomy.
Sure. So if what we're saying is that it was a stage 2 breast cancer that 14 years ago was triple negative, what is affecting the bone now might be that same breast cancer from 14 years ago, or it may be a new tumor that is affecting the bone. And so it would have to be reassessed to see, well, what type of breast cancer is it now, to determine what is the most appropriate treatment for her to get. Is it chemo? Is it hormones, etc.? But usually when that long period of time lapses between disease, usually we want to rebiopsy and redo the IHC so that you can say, okay, is it the same as it was before, or is it different now? And if it's different now, then that will inform the conversation about what kind of treatment is appropriate. But if it is still the same triple negative, then it would, then more chemotherapy would be indicated.
Okay. Well, it is 2 hours and 34 minutes. We're having this magnificent conversation. So before we go, I just want to say thanks again. Thanks a million to all my panelists. But before my experts go, I just want to say, if you have, is there anything that we did not ask that you want to get out, that you want to let us know before you come off? Let me know, because we will take they won't kick us off the airwaves. So I just want to know if you want to let us know anything. Jennifer, let me take you one by one. Doc, anything that we didn't ask that you want to let us know?
You're muted, Jennifer.
Unmute.
Mute, Jennifer.
Okay, yes. I'm sorry. You covered everything. It's just one experience that bothers me in breast cancer treatment. Well, not treatment, but I had a patient who was offered treatment and she went to somebody else, alternatively, who kept injecting the stuff in her. And she says, no, yes, the lump is there, but the cancer is dead. And she came back and it was more angry. And that went on for 8 years. She refused surgery, she refused chemo, she refused radiation. By the time she finally decided to get the traditional treatment, her neck was swollen with nose, she could hardly breathe, she could hardly talk. And she comes in now desperate for traditional chemo and radio and everything, which doesn't work, And I tried to say to her, you lasted so long, 8 years. You would have been well today had you gone traditionally. You would have been. You've wasted too much time. So as you're saying, you lose the time. You can't go back. Lifestyle changes are important, but also traditional medicine has proven to work. It does work. And I say, look at me, I'm an example. It worked for me. So that bothers me when people waste time, because you can't get it back.
Awesome. Dr. Roberts?
Yeah, just to harp on that point too, I think that people need to recognize that the medicine that we practice in the 21st century is not something that I concoct in my kitchen. It's evidence-based medicine. We're taking the best evidence out there from all over the world, trying to tailor it, even evidence locally, to try to tailor it for our patients as best as we can. And as Dr. Mambi Alexander said, it works. And we have the stats to deal with it. No, there might always be exceptions to the rule. And I tired it. Oh, well, Miss Lou down the road, it never worked with her. Yeah, but Miss Lou's an exception, and there are other stories going on with Miss Lou that you're not telling me. But for the most part, these other 1,000 women, it worked, And I want people to feel comfortable to ask their doctors, whether it's me, whether it's the other surgeons, whether it's the hematologist, the radiotherapist, the gynecologist, the GP. They should be able to have good communication in the 21st century with their doctor, where they feel comfortable with their doctor. And for patients, they need to recognize, even though the doctor's the one that's giving them the information, they have full autonomy and they're the ones who are actually in charge of their body fully, 100%.
Thank you. Dr. Smelly?
I think that my take-home message is really that there are a lot of people out there with a lot of opinions on what you should do. You should go to this doctor. You should eat this. You shouldn't eat that. You shouldn't raise your hand too high above your head. What you should only wear red on Tuesdays. There's all kinds of well-meaning but not evidence-based community oncologists out there who want to help you, and it's coming from a good place. And I cannot fault them for wanting the best for you, but just recognize that some of that is overwhelming. It is okay not to take on everything that everybody says to you. And also that, a really common question that comes into my office is, well, what can't I eat? And it's like, there aren't any evil foods. Food is not evil. Food is not intrinsically bad. A lot of us could do better with our diet in terms of being healthier and making healthier choices. And I always will advocate for you to make healthier choices with your diet. Does that mean that you should never have ice cream again? No, that's not what I'm saying. Life is for living. What I'm saying is you can't have ice cream every day because it's bad for you. That is bad for you. And we can all agree that ice cream every day is not going to do you any favors. So I don't want you to get caught up in singling out this particular thing is the reason that I had cancer, that particular thing is the reason that I had cancer. It's multifactorial. There are lots of things that contribute to your individual risk. And, you have to be wary that there's lots of information out there. Not all of it applies to you. Not all of it is something that you need to take on. And so just be willing to have that conversation with us, with your medical team, because we're on your side. We want the best outcome for you. That's why we come to work every day.
Awesome. Raquel?
Let me say traditional medicine. That's why I'm here today. Okay, I'm 8 years strong, and I wouldn't have taken another road anywhere else to do anything else. Traditional medicine, I believe in science, and it's there, it's been proven, and it's 8 years, and you were there in my surgery room, Sandy, and I looked to you and I said, oh, if she's doing 15 years, I can do that too. And I follow traditional. So thank you for the information, and thank you for giving us all that we need to go forward. And for those who are looking in, please understand your body, listen to your practitioner, listen to your body also. Thank you, Sandy.
Okay, Kevin?
Thank you, Sandra. So for me, my final words are, this is a journey that we're on. It's not a sprint, it's a marathon. So, as a caregiver, you're going to need to understand that. You're going to need to understand that you're going to have to be there for physical support, mental support, emotional support. And that, as everybody has been saying, listen to the science. The science has been proven over and over and over to work. Trust the science, but also trust whatever other support systems you have, your faith in God, your faith in the people around you, because that is what's going to take you through the journey. And if you're in doubt, seek opinions of the medical practitioners. If you fear that somebody's giving you wrong information, I have my doctors on speed dial. I'm going to get the confirmation from them. I'm getting the information. Arm yourself with the information. That's the only way to fight this battle of cancer.
Right. And let me just add a word from our viewers. Jennifer says, hi, Jennifer.
Hey.
Excellent forum. Signed in from Florida as a breast cancer patient in treatment in progress, and also a nurse. My Jamaica medical team, you all rock and speak so knowledgeable on the subject, all comparable to my treatment here in the US. So she's bigging up Jamaica. She's bringing up Jamaica and saying that no, we're no better than yard. We are just as good as foreign. Yes, they have maybe more options, or more. They have a wider network than we do, but we can get excellent care here. Am I right, docs? We can get excellent care here. So everybody's saying very informative. Thanking you so much. Thanks, Dr. Smelly. Thanks, Dr. Roberts. Thanks, Dr. Mambi Alexander. Thanks, Althea. Thanks, Kevin. And thanks to the persons who we came up before, Carolyn, Tara, and anybody else? Tara and Carolyn. I am a 22-year survivor. All I said to my doctor was, do what I have to do to be here. 22 years later, I'm living La Vida Loca. One of those persons who put my headspace in the right frame of mind was Dr. Alexander. It is really, really, really very encouraging in the early stages of diagnosis to speak to a survivor who pretty much lets you know, because we're just being realistic. When somebody with two breasts says to you, boy, I know how you feel. No, they don't. No, they don't. Right? Only someone who has been there, done that, and say, I know how you feel, and this is what I did to get through, really resonates with you. So I want to say thank you. It's been 2 hours and 44 minutes. All my faithful viewers online, you have stuck with us throughout this time.
Unmute, Sandra.
You're muted.
Yeah, you're muted. You accidentally muted yourself.
Yes, I want to thank. So thank you, I want to thank our audience that has stuck with us throughout the 2 hours and 44 minutes, because our panelists were so engaging. It was really, really very informative. I learned a lot of stuff myself, because I really didn't know about the triple negative. Because as I say, it's been 22 years and I haven't really gotten involved in depth in the information in recent times. So I thank you all so very much. And please, we're still in the month of October. We have one more Friday left. Wear pink on Friday. It's Pink Fridays. We're still in Pinktober. So please support. Encourage a friend to do a mammogram. If you're below 40, encourage someone to do their self-breast examination. If you have it in your family, please go out and get tested early and save your life. Early detection is key. If you have questions, you can always call the Reach to Recovery desk. There's always someone there to answer the phone and to direct us to someone, because maybe persons are not there in person, but they will get back to you. Just seek the information. Thank you. Have a good evening. God bless. Have a fantastic week. God bless you. Take care of yourselves. Eat right. Balanced diet. Stay healthy. Exercise. Drink lots of water. Good night.